Okay, what's up guys? Today we're gonna cover internal medicine for your shelf exam or for your step 2 CK. So before we start, I just wanted to give some pointers on when you're doing your multiple choice questions. My first tip is rule out the other answers. My second tip is if you know one of the answers to be true and are unsure, then pick the one you know to be true. The third tip is if you don't know, pick the more common things. The fourth tip is keep it simple. The fifth tip is if you don't know, move on quick and then try to save time so you can get the other ones right. My sixth tip is that age is important. My seventh tip is put the whole picture together. And my final tip is when it comes down to two answers, try to reject one of them. First, we're going to cover criterias. So make sure you know CHA2DS2. This is the score that you apply for atrial fibrillation. CHF, hypertension. Age greater than 75 counts as 2. Diabetes, stroke counts as 2. Vascular disease, and such as like peripheral artery disease or coronary artery disease. The next is age, and then the last one is sex category, as in female. So if you have a score of 2 or more, you want to treat with warfarin. If it's less than that, as in 0 or 1, then you treat with aspirin. So next is Centaur criteria for strep pharyngitis. So C stands for no cough, E stands for exudates, N stands for nodes, as in anterior cervical lymph nodes, T stands for temperature if they're febrile, O is for OR, so if it's less than 14 years old, then you add 1. If it's greater than 44 years old, then you minus 1 point. If it's 4 plus, then you treat empirically with penicillin. And if it's 2 to 3, then you want to do a rapid strep. The exception is in kids, you still need to do a rapid strep test no matter what. The next is Pound criteria, which is for migraine headache. So P stands for pulsatile, O stands for 1 day duration, U stands for unilateral, N stands for nausea, and D stands for debilitating. There's no score, but it's kind of just like a mnemonic to help you diagnose migraine headache versus tension headache versus cluster headache. The next is CURB 65 criteria for pneumonia. So C stands for confusion, U stands for uremia, R stands for respiratory rate, as in tachypnea, B stands for blood pressure if they're hypotensive, 65 years old. If the score is 2 or more, you want to hospitalize and treat the pneumonia inpatient. Usually first line inpatient pneumonia is a fluoroquinolone, whereas outpatient, it depends if it's atypical or typical pneumonia. For typical, it'll be amoxicillin, and atypical will be azithromycin. Then the next is SIRS criteria, systemic inflammatory response system. This is kind of the way to start tracking to see if an infection is starting to come on. The first is breathing. So if they're tachypnic, that counts as 1 point. Temperature, if they are febrile or hypothermic, that counts as 1. Next is WBCs. If they have leukocytosis, as in greater than 12K, or leukopenia less than 4K, that's also another point. And then heart rate, if they're tachycardic, that counts as 1. So 2 or more counts as SIRS. If there's a source of infection, then that qualifies as sepsis. If there's infection with evidence of end organ damage or hypotension, then this is called severe sepsis. And then septic shock is if someone is hypotensive and it's not responding to fluids, then that's called septic shock. Next is Light's criteria for pleural effusion. And Light's criteria helps you differentiate from exudate versus transudate. So usually the two things you're going to look at are either protein or LDH, and you compare it from the pleural fluid to serum. So if the ratio is greater than 0.5 for protein, then that is exudative. If it's greater than 0.6 for LDH, then that's also exudative. There's a third one, which is LDH is greater than 2/3 of the upper limit of serum LDH. But in my experience, I find that kind of useless, because most of the time in the questions you'll get, they'll show you the differences between pleural fluid and serum, and then you can calculate the ratio quite easily. So again, if any of those ratios are higher than 0.5 or 0.6, then that's exudate. Your differentials for exudate would be like pneumonia or malignancy, whereas if it's transudative, which is a ratio below that, then it's most likely like CHF, right, which causes backing up into the pulmonary veins and pulmonary capillaries, which causes edema, or cirrhosis, which means that because of you're cirrhotic, you make less albumin, less intravascular oncotic pressure, which causes edema. And then the last most common one would be nephrotic syndrome, where you're urinating out all the proteins, and that decreases intravascular oncotic pressure as well. Next is Wells criteria. Basically, if the score is 4 or more, then you want to do a CT angio. If it's less than 4, then you do a D-dimer. Wells criteria is for PE. Next is COPD. So long-term oxygen therapy criteria, make sure you remember if the oxygen saturation is less than 88, then you want the patient to be on long-term oxygen therapy at home, or if the PaO2 is less than 55. Then next is Glasgow Coma Scale. If the score is 8 or less, that means including 8, then you intubate. Next is ascites analysis. So a score of 250 plus neutrophils is indicative of infection, aka spontaneous bacterial peritonitis. So someone who, and it's usually seen in patients who are cirrhotic and have chronic ascites, they'll have diffuse abdominal pain and fever and leukocytosis. The next step is a paracentesis. If it's greater than 250, that's infection. The next one I want to talk about is the SAG gradient, the serum ascites albumin gradient. So basically, you're measuring the differences in albumin from the serum and the ascites. And then you're going to take the difference between the two, right? And the way I remember which one goes before is it follows the name. So serum minus ascites. So if the score is greater than 1.1, that's portal hypertension. The next is the TIMI score. The TIMI score, if it's between 0 to 2, you want to do a stress test. And the TIMI score is applied for anyone who has unstable angina or NSTEMI. And those with STEMI automatically go to cath lab, but those with unstable angina or NSTEMI are more difficult to figure out how to manage them. So that's where you apply the TIMI score. And if it's between 0 to 2, that's stress test. But if it's 3 or more, then they go to the cath lab. So we're going to start cardiovascular disease. So people who have stable angina, which means that they have substernal chest pain that occurs with exercise or exertion and is alleviated by rest, then this is a sign of stable angina because it improves with rest. People with this, the next thing you want to do is a stress test, right? And there's 3 types of stress tests: an EKG, an echo, or a nuclear perfusion study. So you would do an echo or a nuclear perfusion study if that person has any abnormalities on EKG. So the echo, a positive stress test would be anything that shows ST depression or hypotension or pain. And then, the echo, you might see abnormal wall motion. That would be a positive stress test. And then nuclear perfusion studies would show decreased uptake of nuclear isotope, and that'd be a positive stress test as well. So, and then remember, if they are unable to exercise, then that's when you do a pharmacologic stress test. So there's 2 ways to induce stress on the heart: either exercise or using drugs such as adenosine or dipyridamole. So most of the time, the correct answer will be an exercise stress test using EKG. If they have an abnormal EKG, which will mask the results of a stress EKG, then you either do an echo or nuclear perfusion studies. If they can exercise, then they will exercise on the treadmill. If they can't exercise, as in they are wheelchair bound or have osteoporosis or some other thing that is a contraindication to exercise, then that's when you do a pharmacologic test. And with the pharmacologic test, it can be observed either on EKG, echo, or nuclear perfusion study as well. So, and then remember that the definitive way to actually diagnose coronary artery disease is through angiography. So the reason why you do these stress tests first is because angiography is very invasive, so that's why you do the others first. So the first thing you want to do, first test you want to do with chest pain is EKG. The first line treatment for stable angina is nitrates, aspirin, and beta blockers. First line treatment for unstable angina is the Mona C BASH mnemonic, which is morphine, oxygen, nitrates, aspirin, clopidogrel, beta blockers, ACE inhibitors, statin, and heparin. And remember that the first thing you want to give is aspirin. And remember, if the person has unstable angina, which means the definition of unstable angina means that their angina is worsening or evolving or occurs at rest now, which is different than stable angina. But unstable angina also has no troponin elevations. If you have unstable angina with troponin elevations, and so basically unstable angina becomes NSTEMI as soon as there are any troponins. If there are troponins with ST elevations, then this is what we call a STEMI. But, alright, so when someone comes in with chest pain, the first thing you want to do is rule out acute coronary syndrome. Acute coronary syndrome is unstable angina, NSTEMI, or STEMI. So those are the three types of acute coronary syndrome. So when someone comes in with chest pain, you want to rule that out. So first you do an EKG and cardiac enzymes. But the thing is, cardiac enzymes can take a while to come in. So first thing you want to do is with the EKG is look to see if this is STEMI or not. So if it's STEMI, then to diagnose STEMI, you don't even need cardiac enzymes. All you need is 1 millimeter ST elevations in 2 contiguous leads or a new left bundle branch block with chest pain, and that's considered STEMI. You don't even need the enzymes. If you see those, they go straight to cath lab. And then say you do the EKG, but there are no ST elevations, but they do have the characteristic chest pain that they were describing, then you want to do serial troponins and serial EKGs to see if this is evolving or changing. So then it's either going to be unstable angina or NSTEMI. If the troponins come back updated with elevated troponins, then that's now called an NSTEMI, as a non-ST elevation MI. If there are no troponins yet, and after serial troponin measurements and it stays low, then this is called unstable angina. And remember, the conditions also have to be satisfied where the chest pain has been evolving recently and been getting worse, and this person has been having chest pain at rest. This is called unstable angina. If they have unstable angina or NSTEMI, then you want to apply the TIMI score. If it's 0 to 2, this person will get a stress test. If it's 3 or more, then this person will go to cath lab. Anyone who has chest pain, who has unstable vitals as well, that you suspect MI, they also go straight to cath lab. So those are some exceptions. Main indications for CABG are 3 vessel disease or proximal left anterior descending disease with 70% plus stenosis. Next is Prinzmetal angina, which is basically coronary vasospasm. So the angiography will show vasospasm when given orgonovine or acetylcholine. And you'll also see ST elevation on EKG during these painful episodes. And you want to treat this with calcium channel blockers or nitrates. You only do TPA and MI if there's no access to PCI center. Inferior MI, when you have an myocardial infarction of the inferior wall, which is 2, 3, and AVF, and this is the only MI that has an exception where you don't want to give nitrates because they have a right ventricular MI. The heart is already having problems pumping blood to the left side of the heart. So if you give nitrates, this will exacerbate the hypotension. So actually, in an inferior wall MI, you actually want to give fluids. Sometimes an inferior wall MI can, because the right coronary artery supplies blood to the SA node, this can cause, and then that sinus bradycardia can cause cardiogenic shock. And usually first line for cardiogenic shock is dobutamine, which is a beta 1 agonist. But in the case of a inferior wall MI that has bradycardia and cardiogenic shock, this is due to injury of the SA node. So in this special case, you want to give atropine. Remember that there's only 3 drugs shown to decrease mortality in MI, and this is very high yield, is aspirin, beta blockers, and ACE inhibitors. And nitrates work in 2 ways, but the predominant way it works for MIs is that it decreases preload. It's a venodilator, and that decreases stress on the myocardium due to excess blood. So when you minimize the preload, there's less stress on the heart muscle. And also its secondary effect is it dilates the coronary arteries. So treatment of first degree and second degree heart block, Mobitz 1 is no treatment. But Mobitz 2 and the complete heart block, you want to treat with pacemaker. Dressler syndrome is an autoimmune pericarditis that happens 2 weeks later after an MI. Post-MI, 2 weeks with fever and symptoms of pericarditis with leukocytosis, you want to treat with aspirin. This is contrasted with other causes of pericarditis, such as viral pericarditis. Those will be treated with NSAIDs. This Dressler syndrome is specifically treated with aspirin. And then you have restrictive cardiomyopathy. I just remember the OCs, so hemochromatosis, amyloidosis, sarcoidosis. This creates a diastolic heart failure with reduced ejection fraction. This is due to deposits in the myocardium, so like amyloid deposits or granulomas or iron deposits in the myocardium. What I'm trying to say is remember that hemochromatosis, amyloidosis, and sarcoidosis are associated with restrictive cardiomyopathy. And then remember hemochromatosis is bronze diabetes and iron overload. So they'll have diabetes, bronze skinning, they'll have elevated liver enzymes. Amyloidosis is, think of like protein deposits. You're gonna have deposits in the heart, in the kidney, and in the joints. And in the kidney, you'll see proteinuria. Versus sarcoidosis is where you'll see heart and lung stuff. So bilateral hilar adenopathy, a dry cough, uveitis, erythema nodosum, and also restrictive cardiomyopathy. There are 3 CHF drugs shown to decrease mortality, and that's ACE inhibitors, beta blockers, and spironolactone, which is a potassium-sparing diuretic, which should be contrasted with the 3 drugs that decrease mortality and MI, which is ACE inhibitors as well, and beta blockers as well, but the third is aspirin. Remember metformin, which is a first-line treatment for type 2 diabetes. Remember its contraindications, which is it's contraindicated in renal disease and CHF because it can cause metabolic acidosis. Remember for CHF, acute decompensation of CHF, which means the heart failure is getting worse, then you want to treat it with the mnemonic no-lip. Nitrates, oxygen, loop diuretics, inotropes, and positioning, such as elevating the head of the bed. But the first thing you want to treat with is a loop diuretic, such as furosemide. You need to know supraventricular tachycardia versus ventricular tachycardia. So a supraventricular tachycardia will have narrow QRSs and it'll look like QRST, QRST, QRST. And if they're stable, you treat with adenosine. And if they're unstable, then you want to treat with cardioversion. And then ventricular tachycardia, which has wide bizarre QRS complexes one after another, then you want to treat with amiodarone. And if they're unstable, then you want to treat with cardioversion. Versus VFib and pulseless VTAC, first line treatment for that is defibrillation. Versus asystole and pulseless electrical activity. Pulseless electrical activity means that the EKG shows any rhythm, but when you feel for the pulse, there's no pulse. That means PEA. And then to treat with that is CPR. And by the way, remember that the first line treatment for supraventricular tachycardia before you progress with adenosine is vagal maneuvers, such as carotid massage. So torsades de pointes can lead to VFib, and this is treated with IV magnesium, which stabilizes the cardiac membranes. Next is constrictive pericarditis, which is idiopathic fibrous scarring, replacing the entire pericardial space. The key here I want you to look for is when they do imaging, like a chest x-ray of the heart, you'll see calcifications. Calcifications is key, and it's usually caused by TB or lupus, and it can present similarly to restrictive cardiomyopathy. It can have equal diastolic pressures in all chambers, and it can also have biatrial enlargement, and treatment is pericardiectomy. Acute pericarditis the main cause is Coxsackie virus, and you treat it with an NSAID, versus Dressler, which is treated with aspirin. Aspirin is a type of NSAID, but remember Dressler is aspirin. And on EKG, you'll see diffuse ST elevations, and it's improved with leaning forward. So cardiac tamponade is, just remember Beck's triad, which is hypotension, JVD, and muffled heart sounds. It's also associated with pulsus paradoxus, which means when you inspire, this increases filling to the right ventricle, which causes the interventricular septum to bow over to the left side, which decreases the left ventricular preload. And because of this, the stroke volume is decreased. And because of this, the systolic pressure will drop by greater than 10. And that's called pulsus paradoxus, which means a systolic pressure dropping by greater than 10 upon inspiration. You will see that in cardiac tamponade. It's also associated with electric alternans, which means the QRS voltages the amplitude kind of becomes alternating between big and small, big and small, big and small. And that's because the heart is literally swinging within the pericardial fluid, which distorts the QRS measurements. And then you'll also see low voltage QRS and a Kussmaul sign. Kussmaul sign, which means when you inhale, that the jugular venous distension increases, because with cardiac tamponade, filling of the right side of the heart is more difficult because it's not as compliant. So then the venous blood tends to overflow faster. Remember mitral stenosis? The majority of the causes of mitral stenosis are a previous episode of acute rheumatic fever or rheumatic heart disease. Hypertension or aortic stenosis can over time lead to left ventricular hypertrophy, and if this is prolonged, this can become dilated cardiomyopathy. And people with hypertension or aortic stenosis tend to get angina because of decreased perfusion to the coronary arteries. Another complication is syncope due to decreased perfusion of the brain. Another complication is left ventricular hypertrophy because of increased afterload. Another complication is dilated cardiomyopathy from chronicity. And then you'll hear a soft S2 because the valve doesn't move well. And then definitive diagnosis for aortic stenosis is cardiac catheter to measure the valve area. but an echocardiogram can also measure the valve diameter. If it's less than 1 square centimeter, or if they have any symptoms at all, such as angina, syncope, or CHF, then you want to treat with valve replacement. The tricuspid valve, remember that it's associated with IV drug use and carcinoid syndrome. Carcinoid syndrome is a tumor that produces too much serotonin, and that creates bronchospasm, flushing, diarrhea, and right-sided heart murmurs. 3 causes of holosystolic murmur are mitral regurg, tricuspid regurg, and VSD. So if someone has infective endocarditis, the easiest way to diagnose this is someone who has a fever with leukocytosis and new onset of murmur, and you don't know the bugs yet. Before you find out from your blood culture, which is the first thing you want to do, you treat it empirically with vancomycin and an aminoglycoside. Hypertensive emergency is defined as 180 over 120, and the first line treatments for hypertensive emergency is IV hydralazine, nitroprusside, or labetalol. And remember that for it to be considered an emergency, there has to be evidence of end organ damage. So encephalopathy or acute kidney injury or liver injury, where versus hypertensive urgency is high blood pressure over 180 over 120, but no end organ damage. So the difference is if it's an emergency, you treat IV, but if it's urgency, you treat with oral medications. Subarachnoid hemorrhage, the thunderclap headache, worst headache of your life. First thing you want to do is a CT head without contrast. And if that's negative and you still suspect subarachnoid hemorrhage, the next step is lumbar puncture. And you're going to look for positive xanthochromia, which is the presence of bilirubin in the CSF. Aortic dissection is substernal chest pain that is described as tearing and radiates to the back. And you have 2 types, type A and type B. Type B is anything distal to the left subclavian, and type A is anything proximal to that, and you treat them differently. A goes to surgery right away, and B, you give beta blockers to treat it. And you diagnose an aortic dissection with a CT angio or a transesophageal echo. And remember, any type of CT imaging, make sure to always check the patient's kidneys, because anyone with kidney disease, it's contraindicated to use CT with contrast, which is the majority of CT imaging. Next is peripheral vascular disease or peripheral artery disease. And so the number 1 risk factor is smoking. And to diagnose it, you want to do something called the ankle brachial index, which is measuring the differences in blood pressures from the ankle and the arm. And if the ratio in the ankle to arm is less than 0.9, then that's disease. And if it's less than 0.4, then this is severe disease, which will most likely have pain at rest as well. And people with peripheral artery disease will describe themselves as having claudication in their legs while walking. So they'll walk a certain distance and then feel pain in their legs, and then it improves with rest. It's sort of like stable angina, but of the legs, due to stenosis of the femoral or popliteal arteries. The ones that occur at rest would be synonymous to like unstable angina. And then sometimes they can make clots, which is called acute limb ischemia, which would be synonymous to like an MI. So if someone has a ratio between 0.4 to 0.9, which would be like stable angina, this is the initial stages of peripheral vascular disease. The first line treatment is an exercise program. If they start to have problems at rest and their ratio is below 0.4, now you have to do an intervention such as a stent or a bypass. If they have acute limb ischemia, which is due to some sort of thrombosis that cuts off the circulation in the legs, where everything distal to that starts getting cold and pulseless and in a lot of pain, then you want to treat that with heparin or an embolectomy. Sometimes there's a variation of peripheral vascular disease known as Leriche syndrome, which is caused by atherosclerosis proximal to the aortic bifurcation before they become the iliac arteries. And this person will complain of bilateral leg pain, as well as the key here is impotence and buttock pain. And this is a subtype of variation of the same thing. Remember that IVC filters are placed if contraindicated to heparin or warfarin, or if they've failed previous therapy with heparin or warfarin. If you suspect a PE in a patient, which is basically acute sudden onset of tachypnea, tachycardia, and hypoxemia, the first thing you want to do is give heparin before you even do the CT angio. So heparin and then CT angio. If you had to pick what is the best next step, and both of those are the options, pick heparin first. And then low molecular weight heparins, remember they are contraindicated in renal disease. Someone who has venous insufficiency, look for the medial malleolus ulcer, which is a sign of venous insufficiency, which can be contrasted to other similar presentations such as CHF. Cardiogenic shock, first-line treatment is the inotrope such as dobutamine. Septic shock, first-line treatment is IV antibiotics plus IV fluids and potentially vasopressors. Neurogenic shock, remember everything is down. Cardiac output is down, heart rate is down, total peripheral resistance is down, wedge pressure is down, and the JVD is down. And you treat this with IV fluids. So now we're going to do pulmonology. So COPD is chronic obstructive pulmonary disease, which is seen in chronic smokers and sometimes alpha-1 antitrypsin deficiency. COPD has two different variations. One is chronic bronchitis and the other is emphysema. So chronic bronchitis has excess mucus production from mucus gland hypertrophy, and this narrows the airways, whereas emphysema is where you have destruction of the alveoli. So on auscultation of the lungs, you will hear hyperresonance on percussion, because why? Because the alveoli are all destroyed, so this increases the amount of air in the lungs. You have decreased breath sounds because it's an obstructive lung disease, so it's harder for them to exhale. You'll also hear crackles. Why? Because people with chronic bronchitis will have excess mucus production, and that will produce crackles. Also in the alveoli that are blown out, they will also have excess mucus in there, which causes crackles. And then wheezes is due to airway narrowing from the mucus gland hypertrophy. So only two things decrease mortality in COPD, and that's quitting smoking and home oxygen. And then COPD, the stages are based on FEV1 percentage. So greater than 80% is mild, moderate is 50 to 80, severe is 30 to 50, and very severe is less than 30. And depending on each stage, you have different types of treatments. So for 80 and above, it's albuterol. For 50 to 80, you want to add ipratropium. From 30 to 50, you want to add an inhaled steroid. And for less than 30, that's when you add long-term oxygen. Remember, there are two other indications for adding home oxygen, and that's a PaO2 of less than 55 or an oxygen saturation of less than 88. And then people who have COPD exacerbation, the key I want you to look for here is anyone with COPD who has a change in sputum production, whether it's increased sputum or a change in color. That's an exacerbation. You want to do a chest x-ray to rule out possible pneumonia. But if it's an exacerbation, you add IV steroids and an antibiotic such as fluoroquinolone or azithromycin. And you also give non-invasive positive pressure ventilation, but you don't want to exceed 93% because this can cause shunting. COPD with pneumonia, this is treated with Zosyn or cefepime. Zosyn is also known as piperacillin and tazobactam. But the thing is, I want you to remember a COPD patient with pneumonia, the most common bug is Pseudomonas. Asthma patient with normal, this is high yield. It's a question where a patient who's coming with an acute exacerbation of asthma and they're in respiratory distress, but their PCO2 is normal or elevated. What should you do next? Intubate. Why? Because a patient with asthma should be hyperventilating, so they should have respiratory alkalosis, so their CO2 should actually be low. If it's normal, that means that they're getting tired and they're not able to blow out all the PCO2. So respiratory failure is basically inevitable, so you want to intubate before that happens. So asthma, there's also 4 stages that you need to know. So there's intermittent, mild persistent, moderate persistent, and severe persistent. So mild intermittent is like less than twice a week. Mild persistent is 3 to 7 days a week. Moderate persistent is every day, and severe persistent is multiple times a day. So at each stage, you want to add a different drug. So at mild intermittent, which is less than twice a week, you can just do albuterol PRN. But then as it progresses, you want to add a low steroid, and then the next stage you want to add a medium steroid, and then the final stage you want to add a high dose inhaled steroid. You can also have acute asthma exacerbation, and in this one you want to first give albuterol, but you want to also give IV steroids and oxygen. Whereas in COPD exacerbation, you also give IV steroids and oxygen, but you also add antibiotics. Bronchiectasis is permanent dilatation of the bronchi and loss of cilia caused by recurrent infections. And what this will cause is a lot of mucus. And so this person will be coughing out buckets and buckets of mucus every day. And cystic fibrosis is the most common cause. This is a form of obstructive lung disease because of the blown out bronchi. And you diagnose this with a high resolution CT, and you treat it with bronchodilators. Exacerbations are treated with antibiotics. Cystic fibrosis, this is autosomal recessive. All secretions are thick because the chloride transport channel doesn't work and water will follow it, so all the secretions are very thick. Remember the ages, so less than 20 is associated with Staph aureus, but above 20 is associated with Pseudomonas in terms of pneumonia. And you treat this with supplementing things such as pancreatic enzymes, vitamins D, E, A, K supplementation, and inhaled Dornase, which helps break down the secretions in the lungs. So next, I want to talk about Pancoast tumors. So Pancoast tumors is a lung cancer in the upper lobe of the lung, and this can cause different manifestations and complications. So it can cause Horner syndrome, superior vena cava syndrome, phrenic nerve palsy, recurrent laryngeal nerve palsy. Remember, superior vena cava syndrome is if you have some sort of obstruction that impairs the drainage of the veins into the SVC. So a lung tumor can do that, and it would present with edema of the face and arms. And then Horner syndrome is if you have invasion of the sympathetic ganglion, and then this would give you ptosis, meiosis, and anhidrosis. Sometimes the tumor can invade the brachial plexus, which causes weakness in the right arm. You can have phrenic nerve palsy as well, which causes one diaphragm to be higher than the other. And then recurrent laryngeal nerve palsy, which causes voice hoarseness. So those are the complications. And remember that smokers tend to have central lung tumors, and the most common ones are squamous cell carcinoma or small cell carcinoma. And remember that the squamous cell carcinoma produces PTHRP, parathyroid hormone related peptide, so that can cause hypercalcemia and hypophosphatemia with a low PTH because it's the PTHRP that's causing the hypercalcemia. And then small cell cancers are associated with SIADH, ACTH secretion, and Lambert-Eaton, which is when you have the antibodies presynaptic calcium channel receptor, which prevents the release of acetylcholine at the neuromuscular junction, versus myasthenia gravis, Lambert-Eaton will improve with usage, whereas myasthenia gravis has weakness that worsens with usage. Adenocarcinoma is associated with non-smokers, and they're more on the peripheries. The next point is really high yield. If you have a vignette where a patient has a nodule on chest x-ray, a new nodule, what is the best next step? The best next step is to find a previous chest x-ray to compare. If it changed, then you want to do a CT after that. If you don't have any old imaging in the vignette, like to compare to, then the next step is CT. So signs of pneumothorax would be one-sided decreased breath sounds, hyperresonance, and decreased fremitus. Fremitus is the vibration from palpation. And then versus tension pneumothorax, the key here is the tracheal deviation. And tension pneumothorax will also have hypotension because of compression of the IVC. Yeah, and then remember, they're treated differently. So just a normal pneumothorax, you can treat with a chest tube, whereas tension pneumothorax, you have to do a needle thoracentesis first because it's quicker. This is more urgent right here to release the air, and then you can take your time and put in the chest tube afterwards. Interstitial lung disease, the ABCs of interstitial lung disease are asbestosis, beryllium, coal, silicosis, and sarcoidosis. And on chest x-ray, you will see reticulonodular ground glass appearances or honeycombing. Asbestosis is also associated with pleural plaques and mesothelioma. And then silicosis has the eggshell calcifications of their upper lobes. Speaking of upper lobes, there's 3 things that like to go for the upper lobes, and it's silicosis, TB, and aspergillus. Sarcoidosis can also produce interstitial lung disease, and remember earlier I was saying that it can cause restrictive cardiomyopathy, but for sarcoidosis, remember on chest x-ray you'll see the bilateral hilar adenopathy, and this in sarcoidosis, all the vignettes look at the calcium. They'll always have hypercalcemia because the granulomas tend to make more calcium. And then ACE enzyme is also elevated, and you treat this with steroids. So for respiratory failure, people who have low PaO2 think of lung diseases, and people who have a high PCO2 think of hypoventilation. And that means they have difficulty getting air out. So think of like obesity hypoventilation or COPD. Whereas a low PaO2, think of like interstitial lung disease. Next, you need to know about the basics of mechanical ventilation. So there are 4 parameters, and so there's tidal volume and respiratory rate, and there's FiO2 and PEEP, and each one of them either helps manipulate PCO2 or PaO2. So in terms of PCO2, this is for ventilation. So tidal volume and respiratory rate will help alter your PCO2 levels. If you increase tidal volume, then you can exhale your PCO2 more. So increasing tidal volume will lower the PCO2 more, and increasing respiratory rate will also lower PCO2 and vice versa. And then PaO2 is an analog of oxygenation. So you can control that with FiO2 and PEEP. The higher the FiO2, the higher the PaO2. The higher the PEEP, the higher the PaO2, and vice versa. And you'll get a question where someone's on mechanical ventilation and their PCO2 might be too high out of the normal range, and they'll ask you, what should you change? And then look for either increasing tidal volume or respiratory rate. Usually, the tidal volume is a better answer than respiratory rate because it can change the PCO2 more efficiently. ARDS is caused by some sort of systemic infection like pyelonephritis or like severe pancreatitis. And this is where you have increased vasodilation of the pulmonary capillaries, which causes leakage into the alveoli, and then collapsing of the alveoli. and you want to treat this with high PEEP and low tidal volume. So remember, high PEEP. Pulmonary hypertension is diagnosed with pulmonary artery pressure greater than 25, and this is just something you have to memorize because a lot of times in the questions, some of the things you need to just memorize because they're not in the lab values. Another thing that you might want to memorize is like lactate is normal, is less than 1. Over 1 is considered lactic acidosis. Aspiration pneumonia, this is caused by people who are on mechanical ventilation or people who have impaired gag reflexes, such as those with dementia or seizures or alcoholics or stroke patients. And you want to first, and it'll cause right lower lobe pneumonias or abscesses, and you want to treat this with an antibiotic that covers anaerobes, and that's clindamycin. Pneumocystis jirovecii is an opportunistic infection in patients with AIDS or those who are immunosuppressed from transplant, organ transplant, and you prophylax and treat with TMP SMX. And this is the kicker, is you gotta remember, when do you give steroids in a pneumocystis jirovecii infection? And you give steroids if the PaO2 is less than 70 or the AA gradient is greater than 35. And remember, in AIDS patients, you start giving prophylaxis for TMP SMX at a CD4 less than 200. And also know how it presents, which is basically like the atypical pneumonia, which is fever, non-productive cough with bilateral interstitial infiltrates. Alright, next we're going to talk about GI. So staging of colon cancer is done with CT. So most cancers, after you diagnose it, they'll ask you what's the next thing to do. And always think about staging with CT next. So whether it's colon cancer, ovarian cancer, lung cancer, best next step after diagnosis is a CT. Diverticulosis is diagnosed with a barium enema. It causes a lot of blood in the toilet bowl. And then diverticulitis, diagnosed with a CT scan with contrast. Acute mesenteric ischemia is diagnosed with angiography. And remember, this is the one where it's basically an MI of the mesenteric arteries due to emboli or thrombosis. And the key here is pain out of proportion. The patient will have extreme abdominal pain, but the physical abdominal exam will be unimpressive. No peritonitis, no guarding, no rigidity, very mild tenderness to palpation, and usually multiple risk factors for atherosclerotic cardiovascular disease like hypertension, hyperlipidemia, diabetes, smoking. That's kind of the vignette for acute mesenteric ischemia. Also associated with AFib, because AFib is going to build up those thrombi that will embolize to the mesenteric arteries. Ogilvie syndrome is, just think of like ileus of the colon. It's isolated. So on abdominal x-ray, you'll see a distended colon, but the small intestines look okay. This is usually in an older person post-op. Another post-op kind of presentation that's similar to this is post-op paralytic ileus, but the difference here is that the small bowel and the colon will both be distended, and the key here is that in ileus there will be decreased bowel sounds. Sigmoid volvulus is treated with a sigmoidoscopy, and then on abdominal x-ray, that's where you'll see the omega sign, or like the beam sign. When you put the scope up, it will help detours the volvulus. Remember, for varices secondary to cirrhosis, first line meds or octreotide, and then for prophylaxis is a beta blocker, because octreotide is actually a splanchnic vessel vasoconstrictor, and that prevents blood from reaching the venous side, and by doing that it helps alleviate the amount of blood in the portal system, in the veins. Next is spontaneous bacterial peritonitis. I already talked about this, but anyone with cirrhosis with chronic ascites who develops a fever and diffuse abdominal pain, think of spontaneous bacterial peritonitis, you diagnose it with a paracentesis, which shows lots of neutrophils greater than 250, and that's diagnostic, and you treat that with ceftriaxone. Remember, a young girl who takes an oral contraceptive pill who has a new mass on the liver, the diagnosis is a hepatic adenoma. So this is highly associated with a young girl taking an OCP, and you only resect it if it's greater than 5 centimeters. Next is the liver abscesses and cysts. So you have a hydatid liver cyst, which is caused by Echinococcus, and this is associated with people from Latin America who have had close contacts with dogs. Those are your buzzwords. And you treat it with resection and mebendazole. On right upper quadrant ultrasound, you will see a round shape with a lot of other small cysts within it. Many multiple cysts within cysts. And then a pyogenic liver abscess is a complication of ascending cholangitis. And then ascending cholangitis is a complication of choledocholithiasis. So if you have inflammation and infection of the common bile duct, this can ascend up to the liver and cause a pyogenic liver abscess. The most common cause is E. coli. You diagnose it with the ultrasound or CT, and to treat it, you do an IND plus antibiotics. Remember, with this one, if you leave it alone, it can be fatal. The last is amoeba liver abscess, caused by Entamoeba histolytica. And the buzzwords are fever, right upper quadrant pain, plus diarrhea. And so the other liver cysts won't really have diarrhea, which makes the amoebic liver abscess stand out. And you treat this with metronidazole. Oh, also in the amoebic liver abscess, the patient will also have eosinophilia because this is a parasite. And remember, parasites will cause elevations in eosinophils. Physiologic jaundice of the newborn. This is due to an immature conjugating system, and this causes a indirect hyperbilirubinemia, which is the same as unconjugated hyperbilirubinemia, and this will happen after a few days of life. Remember that if a newborn has jaundice right at birth, this is pathologic, and the next best step is a Coombs test. Crigler-Najjar is due to deficiency of glucuronoltransferase, and that causes an unconjugated hyperbilirubinemia. And think of Gilbert disease as like Crigler-Najjar light. This person has a deficiency, not a complete deficiency of glucuronoltransferase. It's only apparent when they're sick. So the vignette will be like a 20-year-old guy who recently had some sort of infection and now he has jaundice. That is unconjugated hyperbilirubinemia. This is Gilbert's syndrome. And then there's Dubin-Johnson, which is where the hepatocytes are able to conjugate bilirubin, but they can't release it. So the patient will have a black liver. And then Rotor is basically Dubin-Johnson light, which is the same mechanism, but they will have a normal colored liver. And then the mnemonic for causes of elevated AST and ALT are A, B, C, D, E, F, G, H, I. So autoimmune, hepatitis B, hepatitis C, drugs, ethanol, fatty liver, growths like tumors, hemodynamic instability like hypotension, which can lead to shock liver, and iron, such as iron overload, seen in hemochromatosis. If you suspect cholecystitis, what's the best next step? Right upper quadrant ultrasound. If it's equivocal, which means they have all the signs of cholecystitis, right upper quadrant pain, fever, leukocytosis, a positive Murphy sign, and then you do the right upper quadrant ultrasound, but there's no gallbladder wall thickening, no pericholecystic fluid, no gallstones present. What's the next step? Is a HIDA scan. The HIDA scan is a dye which lights up the entire biliary tree, And if the gallbladder doesn't light up, that means that there's a stone there blocking it, and that will help you diagnose cholecystitis. So HIDA scan is used if the right upper quadrant ultrasound is non-diagnostic. And to diagnose cholecystitis, you need 2 of the 3 on right upper quadrant ultrasound, which is what I said earlier: pericholecystic fluid, gallbladder wall thickening, which means greater than 4 millimeters, and gallstones present. Again, choledocholithiasis is the presence of a stone lodged in the common bile duct. If this is there long enough, this can cause an infection such as ascending cholangitis. And ascending cholangitis is classified with the triad of Charcot's triad, which is right upper quadrant pain, fever, and jaundice. And this can be expanded further to something called Reynolds pentad, which adds altered mental status plus hypotension. So cholangitis, ascending cholangitis, remember the main cause is E. coli, and if that ascends further up, that can cause a pyogenic liver abscess. But before that complication happens, if you catch ascending cholangitis, you're going to treat it with IV fluids, IV antibiotics, and one type of intervention. What is it? It's going to be an ERCP. You go through endoscopic retrograde cholangiopancreatography and retrieve that stone. Another complication of choledocholithiasis is that it can go down and obstruct the pancreatic duct. It can do that, but a lot of times you won't find it. But this will cause something called gallstone pancreatitis. And then so this is a classic board question as well, is someone who has been diagnosed with pancreatitis through elevated lipase amylase and with the clinical signs and symptoms of pancreatitis, and the diagnosis is clear, what's the best next step in terms of imaging? CT abdomen or right upper quadrant ultrasound? The answer will be right upper quadrant ultrasound because the amylase and lipase are already elevated. You don't need a CT to diagnose pancreatitis. So the best next imaging is finding the source. And the most common source is gallstones. And the second most common is alcohol. So if you find gallstones, you found your culprit. The next thing you need to know is that this patient needs a cholecystectomy within the same hospital visit because it's just going to happen again. And so you might as well eliminate the source. One other final complication of cholecystitis is that sometimes the stone can erode through the gallbladder and erode through adjacent small intestine, and this can go all the way down to the terminal ileum and cause a blockage there, and that's called gallstone ileus. So a person will have the presence of air in the gallbladder wall, and this is called gallstone ileus, and the patient will present with symptoms of small bowel obstruction. So they'll have distension proximal to the ileus, possible small air fluid levels, and also hyperactive bowel sounds with nausea and bilious vomiting and obstipation, which means constipation plus not passing gas, and diffuse abdominal pain. So that is the last complication of cholecystitis. Actually, just kidding. There's one more complication of cholecystitis, which is in an ICU patient. This is a classic question as well. An ICU patient can actually get predisposed to something called acalculous cholecystitis, which means the ICU patient is usually on TPN a lot, and that means that their gallbladder is underactive. It doesn't contract a lot, and this can predispose to bacterial colonization. The second one is to prolonged ischemia, which causes ischemia of the gallbladder, and this will cause acalculous cholecystitis. And then the right upper quadrant ultrasound will show no stones, but everything else is indicating that there's a cholecystitis, and they'll ask you, how do you treat it? And you treat acalculous cholecystitis with percutaneous cholecystostomy. So that means you're draining, putting a tube through the skin and through the gallbladder, and you're draining it through the skin. Remember, primary sclerosing cholangitis, which is when you get the beaded appearance of the biliary tree. This is highly associated with ulcerative colitis. They always like to ask this. A patient with ulcerative colitis has an association with primary sclerosing cholangitis. And then primary biliary cirrhosis, which is also known as primary biliary cholangitis. It's autoimmune. Remember, it has the anti-mitochondrial antibodies, and the key here is that they have extreme pruritus. You want to treat this with ursodiol. Appendicitis, remember, is diagnosed clinically. Sometimes they might ask you what's the best next step, and it'll say A, appendectomy, B, CT of the abdomen, and this can be tricky. But you only do a CT if the diagnosis of appendicitis isn't clear cut. So maybe they'll have right lower quadrant pain, but like a negative Rovsing or like a negative SOA sign or no rebound tenderness, but it seems so much like it. So that's when you would do a CT. But if they have all the positive signs of appendicitis, like nausea, vomiting, right lower quadrant pain that started periumbilical, it's at McBurney's point, there's a positive Rovsing sign, positive rebound tenderness, positive SOA sign, they have zero appetite, and fever, leukocytosis, the diagnosis is clear cut, the answer will be appendectomy. But if any of those kind of are contradicted, then pick CT scan. And this one requires a little bit of finesse, but just that's kind of the point they're trying to get at, is that appendicitis is able to be diagnosed clinically. Carcinoid tumor secretes serotonin. It's most commonly found in the appendix and the small bowel. Remember that these people are prone to niacin deficiency because if you remember, tryptophan makes serotonin, melatonin, and niacin. And if you have a lot of serotonin due to a carcinoid tumor, then this will hog up all the tryptophan. And then the person will be left with no niacin and melatonin. And then niacin, which is vitamin B3, has the 3Ds, remember? Diarrhea, dermatitis, and dementia. And carcinoid tumors have the BFDR mnemonic, bronchospasm, flushing, diarrhea, and right-sided heart valve abnormalities. Pancreatic pseudocyst is a common complication of pancreatitis. It's a cyst that appears 2 to 3 weeks after acute pancreatitis, and usually the person will have early satiety, distended abdomen, and like vague abdominal pain, and then imaging will show a cyst, and then the answer is usually observe, but if it's really big, like 5 centimeters or greater, then you drain it. And then chronic pancreatitis, I just want you to remember the buzzword calcification. So chronic pancreatitis will have calcifications. And then this is a common complication of aortic surgery that I want you to remember is a aortoenteric fistula, which is from after aorta surgery, the patient's aorta can actually, kind of like the gallstone-Ilias mechanism, a hole can erode through the aorta into the intestines, and then so you'll have a lot of bleeding from the aorta crossing over into the GI system. So this patient will have bright red blood per rectum and a recent aortic surgery, and this is aortoenteric fistula. Achalasia is failure of the lower esophageal sphincter to relax. Remember that. The mechanism is failure to relax. And then any patient who has problems swallowing, such as dysphagia, remember the first line imaging is a barium swallow. So the differentials could be Zenker's, it could be an esophageal cancer, it could be esophageal spasm, it could be Crest syndrome, and it could be esophageal stricture. The list is endless, but anytime someone has problems swallowing, the first step is barium swallow, unless they have alarm symptoms. And alarm symptoms would be anyone who's greater than 55 years old with problems swallowing and weight loss. Remember, as Zenker's diverticulum, the vignette will be an old man who has difficulty when they eat, they feel like they get food stuck in the back of their throat and it doesn't go all the way down. And also, they'll have the buzzword here is halitosis, really smelly breath. Remember that GERD can predispose to esophageal stricture, and this can cause difficulty with swallowing foods and liquids. The most common cause of peptic ulcer disease, which basically means gastric or duodenal ulcers, is H. pylori or NSAID use. Remember, anyone who comes in with gastritis, symptoms of heartburn, symptoms of GERD, if they're young and from North America, the first line treatment is proton pump inhibitor therapy and to come back in a few weeks to see if that helps. If they're from another country where H. pylori is very prevalent, like Asia, for example, then the first thing you want to do is offer H. pylori testing through the urease breath test or the H. pylori fecal antigen testing. But if anyone has symptoms of heartburn, GERD, gastritis, but have alarm symptoms, then the next best step, this is high yield, is endoscopy. So alarm symptoms would be microcytic anemia, weight loss, or elderly age, so 55 years or older. If someone comes in with symptoms of heartburn and they are 55 years or older, then the next best step is endoscopy. The next thing too is anyone who's older than 50 years old who has microcytic anemia due to iron deficiency anemia. This is colon cancer until proven otherwise. So the next best step, very classic question, is a colonoscopy. And remember, you do a colonoscopy when people turn 50 years old, and you do it every 10 years. And unless they had a family member who had colon cancer before the age of 60, then you want to do this at 40 years old or 10 years before the relative was diagnosed with cancer, whatever one comes first. Inflammatory bowel disease is either Crohn's disease or ulcerative colitis. And remember, Crohn's disease has skip lesions. It can also include the oral mucosa, like oral ulcers, and it's associated with stricture and fistulas, whereas ulcerative colitis always includes the rectum, and this is only mucosal, whereas Crohn's is transmural. And then this one happens in like giant strips and is continuous. And then remember that ulcerative colitis is associated with primary sclerosing cholangitis, and inflammatory bowel disease is treated with sulfasalazines, and in acute flares it's treated with steroids. And inflammatory bowel disease has a high yield cutaneous association, which is pyoderma gangrenosum. This is associated with IBD, and pyoderma gangrenosum is a sterile wound, and it's treated with steroids, not antibiotics, because it's sterile. It's treated with steroids. And that is gastroenterology. All right, now we're going to talk about endocrine. So remember, with the first thing you want to do with a new thyroid nodule is TSH and ultrasound. So TSH helps determine whether the nodule is hyperthyroid or euthyroid. Hyperthyroid nodules are usually not malignant, whereas euthyroid nodules tend to be, well, most malignant nodules are euthyroid. The ultrasound gives you visual information, whether it's cystic, if it's multiloculated, which could be a sign of cancer, or the size, whether it's greater than a centimeter or less than a centimeter. So it's important to know the diagnostic algorithm. So basically, if the person has a hyperthyroid nodule, the next best step is radioactive iodine uptake. And this will help tell whether it's diffuse or one nodule or multinodular. So if it's diffuse, that's Graves' disease. If it's one area, then that's toxic adenoma, just one area. If it's patchy and multiple, then that's a multinodular toxic goiter, which is also known as Plummer disease. If they are euthyroid, then the next thing you want to do is if it's greater than a centimeter, then you biopsy. If it's less than a centimeter, then you wait and follow up in a few weeks, because less than a centimeter has a low likelihood of malignancy. So another thing too is sometimes a patient can be hyperthyroid with zero radioactive iodine uptake. What's happening there? So basically, radioactive iodine uptake is an indicator of how much thyroid hormone is actually being made. It's like a thyroid factory. So if there's uptake, you know that that thyroid gland is taking up the iodine and making more. Sometimes you can be hyperthyroid and have no uptake. So what does that mean? No uptake means not actively making thyroid, and basically think of like a bursted gland or an inflamed gland. So classic examples of hyperthyroid with no uptake would be like postpartum thyroiditis or de Quervain disease, which is also known as subacute thyroiditis, or you can think of Hashimoto's thyroiditis, which can have a hyperthyroid phase. So what that means is that they're not actively making thyroid, but the thyroid gland is leaking out preformed thyroid. So it's basically like a dam that has broken open. And so all that preformed thyroid hormone is out in the circulation, but that factory is broken. They're not making any more new thyroid. So when you see someone who's hyperthyroid with no uptake, think of the diseases that cause inflammation of the thyroid that would cause it to leak out. So next is when you have excess estrogen, whether it's through medications or pregnancy, this increases the thyroid binding globulin, and because this increases, then it kind of attaches to all the thyroid hormone, and that the thyroid hormone under a healthy normal person will make more thyroid hormone to keep up with the new TBG being made. But people who are hypothyroid already can't make enough thyroid. So when they are pregnant or taking OCPs, the TBG will increase, but their thyroid won't be able to keep up with all that new TBG, which is binding up all the thyroid hormone. So then they become even more thyroid deficient. So my point is that people who are pregnant or on OCPs who are hypothyroid need to increase their levothyroxine dosages to keep up with the increased TBG. So anyone who's pregnant or taking OCPs who is hypothyroid needs to take more levothyroxine than their usual dose. Hashimoto's is also known as chronic lymphocytic thyroiditis, and this is associated with other autoimmune diseases such as lupus or pernicious anemia or Sjogren's disease. Remember, as a general rule, anyone who has autoimmune disease is automatically more prone to getting other autoimmune diseases. And the key higher yield thing I want you to know with Hashimoto's is that it's associated with thyroid lymphoma. So subacute de Quervain thyroiditis is, remember the key here is they're hyperthyroid, but out of all of the hyperthyroidisms, the buzzword here is painful. So a hyperthyroid patient with a painful thyroid who recently had an upper respiratory tract infection, this is subacute de Quervain thyroiditis. And remember, this is caused by leakage of excess thyroid hormone. So think back to when I was talking about radioactive uptake. This will have decreased uptake. And you treat this with NSAIDs or aspirin. And then the last is medullary thyroid cancer. Remember, this arises from the parafollicular C cells, which make calcitonin. Calcitonin helps bring calcium levels back down, whereas parathyroid hormone is made by the parathyroid gland, which helps increase calcium. So they're in different glands that oppose each other, so that can be confusing. So make sure you review your anatomy if that's fuzzy. But medullary thyroid cancer, I want you to remember that a lot of times when this is diagnosed, the treatment is surgery. But before you treat with surgery, you have to remember that medullary thyroid cancer is part of the MEN2A and MEN2B diseases. And remember, MEN2A is PPM and MEN2B is PMM. So pheochromocytoma, hyperparathyroidism, and medullary thyroid cancer. And MEN2B is pheochromocytoma, medullary thyroid cancer, and mucosal neuromas or marfanoid habitus. And so as soon as you think of medullary thyroid cancer, you have to remember, oh, MEN2A, MEN2B. And because of that, the next best step is to assess for those other diseases. Why? The most important one you want to check for is pheochromocytoma. So if they say this person was diagnosed with medullary thyroid cancer, what's the best next step? A, thyroidectomy. B, urine metanephrines. C, D, E, etc. The answer is urine metanephrines. Why? Because you gotta assess if they have pheochromocytoma. Why? Because if you don't and you do thyroid surgery, what if they have an episode of pheochromocytoma where they get a hypertensive emergency and just bleed out and die? So that's why it's really important to make sure that they don't have pheochromocytoma. So again, to diagnose pheochromocytoma, it's urine metanephrines. That's one of the classic board questions they ask with medullary thyroid cancer to see if you know what are the MEN2A and MEN2B diseases. And then on top of that, what kind of blood test would you order to be able to diagnose pheochromocytoma? So there's multiple layers to that, and that's why it's a classic board question. So acromegaly is caused by excess growth hormone in the pituitary. And remember that the first test, is it A, growth hormone, or B, IGF-1? The answer is IGF-1, which is released by the liver, which is stimulated by growth hormone. This is more reliable than growth hormone because the levels are consistently high in acromegaly versus growth hormone, which the levels can fluctuate. The first line treatment for SIADH is water restriction. So anyone you suspect with Cushing syndrome, remember there's a mnemonic BAM Cushingoid, buffalo hump, amenorrhea, moon crazy, ulcers, skin changes, hypertension, infection, necrosis of the femoral head, glaucoma, osteoporosis, immunosuppression, and diabetes. The first test is an overnight dexamethasone suppression test, a 24-hour cortisol level, or a late night salivary cortisol level. For adrenal insufficiency, the first test will be urine cortisol or ACTH stimulation. If the ACTH stimulation test boosts up the cortisol levels, then you know that this is a secondary adrenal insufficiency caused by the pituitary gland. Whereas if it doesn't go up, then you know this is a primary adrenal insufficiency, which is an adrenal problem. And that's called Addison's disease. And Addison disease, the most common cause is autoimmune. So the next is if a patient has hypertension with hypernatremia and hypokalemia, then the first step you want to do is a renin to aldosterone ratio. So why is that? Because you want to determine if the cause of this hyperaldosteronism is adrenal problem or if it's due to an underperfusion of the kidneys problem, mainly renal artery stenosis or fibromuscular dysplasia. So if the aldosterone is high and the renin is low, then this suggests an adrenal problem, which is called Conn syndrome. Whereas if the renin is high and then the aldosterone is high, this suggests a renal artery stenosis or fibromuscular dysplasia, because stenosis of the renal artery will cause decreased perfusion to the JG cells, and then the JG cells will increase renin. And remember the RAS system, renin will convert angiotensinogen to angiotensin 1, And then ACE, angiotensin converting enzyme, will convert angiotensin 1 to angiotensin 2. And then angiotensin 2 goes all the way to the adrenal cortex. Remember, there's 3 layers: the zona glomerulosa, the zona fascicularis, and the zona reticularis. And then salt, sugar, sex. So aldosterone in the outermost layer, cortisol in the middle layer, and sex hormones in the innermost layer. The medulla underneath that is where catecholamines are released. That's where pheochromocytoma happens. But the angiotensin 2 will go to zona glomerulosa and then increase the synthesis of aldosterone. Aldosterone will then go all the way to the principal cells. The principal cells, remember, aldosterone is a steroid hormone. So steroid hormones work intracellularly. It'll go inside the cell and bind the aldosterone mineralocorticoid receptors, and this will increase transcription and translation of the ENaC channel. And then that will help draw in sodium, and the potassium channel will excrete potassium, and that with bringing in sodium, water will follow. So this person will have hypernatremia, hypokalemia, and with the increased water will lead to hypertension. So that's why with people with hypertension, hypernatremia, and hypokalemia, the first thing you want to do is a renin to aldosterone ratio to help narrow your differential. Remember, the classic patient with renal artery stenosis is an older person with a history of hypertension that's been well controlled, and now all of a sudden they've been adherent to their medications. Now all of a sudden their blood pressure is out of control and multiple medications aren't helping, and it's being refractory to treatment. You should think of renal artery stenosis. In addition to that, on abdominal auscultation, there will be a murmur over the renal artery. Whereas fibromuscular dysplasia, the stereotypical classic patient will be a young female who has a bruit over the renal arteries with unexplained hypertension, with, like I said again, hypernatremia, hypokalemia. And also, in fibromuscular dysplasia, it's associated with a subauricular bruit, a bruit by the ears. So diabetes mellitus is diagnosed 3 ways: either 2 fasting readings of greater than 126, random glucose level of 200 with symptoms such as polyphagia, polydipsia, polyuria, dehydration, weight loss, or a hemoglobin A1C of 6.5 plus. Remember, metformin is contraindicated in CHF and kidney failure because it can exacerbate lactic acidosis. Metformin is contraindicated when creatinine levels are greater than 1.5. Sometimes they like to ask you what are the effects of metformin, and the 3 big ones are: it enhances insulin sensitivity, it blocks gluconeogenesis, and it decreases GI absorption. Metformin is also the first-line treatment of type 2 diabetes. The most common cause of death in a diabetic patient is myocardial infarction due to accelerated atherosclerosis. It's also, on a side note, the most common cause of death in rheumatoid arthritis is also myocardial infarction due to the same mechanism. So you should know the difference between hyperglycemic, hyperosmotic state versus DKA. And the main kicker is the pH. So a person with DKA will have anion gap metabolic acidosis, whereas the person with HHS won't. And the glucose levels are very different too. A person with HHS will have glucose levels of near 1,000, whereas a person with DKA has glucose levels of around 300 to 500. So those are the 2 main differences. And then remember, DKA, you're gonna have anion gap metabolic acidosis, right? So a pH of less than 7.35, right? And then the anion gap will be sodium minus chloride minus bicarb, which will be greater than, the sources always change. Sometimes it's 8 to 12, sometimes it's 8 to 16. I use 8 to 16. Anything greater than 16 is an anion gap metabolic acidosis. This person usually is a type 1 diabetic who's not making any insulin, they'll have abdominal pain, nausea, and vomiting, and they'll have respiratory alkalosis to compensate for the metabolic acidosis. This is called Kussmaul's breathing. Deep tachypnea with giant tidal volumes. You want to treat this with continuous insulin and IV fluids, and you would give potassium if the potassium levels drop below 5.2, because sometimes they show hyperkalemia, but their whole body is actually potassium deficient due to the hydrogen potassium exchanger. So remember, if you're acidotic, the hydrogen out in the blood will want to go into the cells, and this will exchange with potassium. And if this keeps happening, the intracellular stores of potassium are depleted, but the vascular stores of potassium are increased. So you want to monitor the potassium. And the question here is, when do you stop giving insulin? And that's when the anion gap has closed. Whereas HHS is treated with IV fluids and insulin as well. And then last is Zollinger-Ellison, which is gastrin tumor. You'll see multiple duodenal ulcers with diarrhea, and you diagnose that with gastrin levels, and the gastrin levels will be over 1,000. And then the next thing you'll do is a secretin challenge, and secretin usually lowers gastrin levels, but it doesn't lower the gastrin levels in this case. And this is a diagnosis of Zollinger-Ellison, and treatment is proton pump inhibitor or surgery. And last is glucagonoma, and the key here is hyperglycemia plus a classic rash called necrotizing migratory erythema. If you see this rash, it's a glucagonoma. And then speaking of glucagon, if someone has beta blocker overdose, what's the antidote? It's glucagon. And that is endocrine. Next is CT and joint diseases. So a fetus with congenital heart block, what does that mean? It's associated with neonatal lupus. So I want you to know the treatment regimens for rheumatoid arthritis and lupus. So rheumatoid arthritis for mild, so they have similar treatments. That's why I wanted to compare and contrast them. So rheumatoid arthritis mild disease is treated with NSAIDs. And then the disease modifying drug of choice is methotrexate. And for rheumatoid arthritis flares, it's treated with steroids. Versus lupus, the mild version of lupus is treated with NSAIDs. The disease modifying is hydroxychloroquine, so the disease modifying drugs are different. And then for flares is also steroids. And you diagnose rheumatoid arthritis based on the clinical presentation of bilateral symmetric metacarpal phalangeal and proximal interphalangeal joint stiffness and erythema that's worse in the morning and improves throughout the day. It spares the DIP. What you'll do is it'll have elevated ANA, elevated rheumatoid factor, and the specific one is elevated anti-citrulline protein, anti-CCP. And then versus lupus, there's a mnemonic SOAP brain MD, serositis, so all they could have pleuritis, pericarditis, oral ulcers, arthritis, photosensitivity, which means that their skin gets burned really easily and blisters easily. Blood, so pancytopenia, anemia, thrombocytopenia, leukopenia. Renal, they can have lupus nephritic syndrome, which is a combination of hematuria and proteinuria. ANA, I is immunoglobulins, so that should remind you of anti-double-stranded DNA and anti-Smith antibodies. And then N for neuro, there can be psychiatric manifestations of lupus, and M for malar rash, and D for discoid rash. So 4 out of those 11 means that there's a 99% chance that you have lupus. The next is antiphospholipid syndrome. This person is the female who has had recurrent miscarriages and random episodes of thrombotic episodes like DVT or PE, and it usually has a prolonged PTT and PT that isn't corrected by a mixing study. And they also have false elevations of VDRL, so false syphilis positives. And remember that this person has a hypercoagulable state. So gout is a sudden onset of super painful joint. The classic joint is the metatarsophalangeal joint. The base of the big toe will be inflamed and swollen, and it'll be super painful with an acute onset that can even wake the patient up at night. The next step is arthrocentesis. You want to analyze the fluid, and in the fluid, it'll show negatively birefringent crystals, which will be yellow needle-shaped crystals. That will be diagnostic for gout. If there are positively birefringent crystals, rhomboid-shaped crystals, then this is called pseudogout. And pseudogout is associated with chondrocalcinosis, which is where on x-ray you'll see calcifications of cartilage. And then gout, the acute flare, is treated with NSAIDs or colchicine. The contraindication for that is kidney disease. So someone with CKD, you can't give NSAIDs or colchicine. So then the next treatment would be intra-articular steroids. The next is knowing the difference between polymyositis versus polymyalgia rheumatica versus fibromyalgia. They love to test you on knowing the differences, but the key thing here is that polymyalgia rheumatica is think stiffness, polymyositis think weakness, and fibromyalgia think pain. So those are your starting points. So let's start with polymyositis. So this person has symmetric weakness. CPK will be elevated because this is due to inflammation of the muscles. So CPK is a muscle enzyme, so this will be elevated, and you treat this with steroids. Polymyositis also can have cutaneous manifestations. The two high yields ones are Gottron's papules, which are red papules over the knuckles, and heliotrope rash, which is a rash around the orbit of the eye. The key thing here too I want you to remember is that polymyositis is usually associated with the underlying malignancy. Next is polymyalgia rheumatica. Polymyalgia rheumatica, think of an elderly patient with stiffness and pain in their hip and shoulders, and usually this person will have an elevated ESR, but the CPK will be normal, and then you treat this with low dose steroids. Polymyalgia rheumatica is also associated with something called temporal arteritis or giant cell arteritis, which is vasculitis of the temporal artery along the side of the head. It'll be big and inflamed, and this is an emergency because it can cause blindness. So you want to treat that. Well, when you biopsy it, you'll see giant cells, but you want to treat it with high dose steroids. And polymyalgia rheumatica is extremely responsive to steroids, so they'll see immediate improvement. Last is fibromyalgia, and I want you to think about pain, especially over the trigger points. So they have symmetric pain on pressure points over the neck, the shoulders, the butt, the knees, all along the back, and the pain is considered constant and aching. Remember that this person is associated with mood disorders and somatic symptom disorders. The treatment for this is either a TCA or a SNRI like venlafaxine. And then anybody with a sudden onset of psoriasis or people who have molluscum contagiosum, remember that this is associated with HIV. So the best next step is to test for HIV, and that is CT and joint diseases. All right, next is renal. So white blood cell casts in urine. The two big ones I want you to think about are acute interstitial nephritis and pyelonephritis. So uremia, so that's from kidney disease where the urea levels are really high. It can impair platelet function, so this can cause an increased bleeding time. But there are 4 manifestations of uremia that I want you to remember that are indications for dialysis. So one is hemolytic uremic syndrome, which is a form of microangiopathic hemolytic anemia. Remember that this is where you get the platelets clumping and then the red blood cells going by, and then they shear, which causes thrombocytopenia and anemia. That's HUS, which can also be precipitated by enterohemorrhagic E. coli, EHEC, which is associated with eating undercooked burgers. And usually people with EHEC, when they're treated with antibiotics such as fluoroquinolones, will lead to HUS, but uremia can also lead to HUS. The second is uremic pericarditis. People have chronic kidney disease with pericarditis. That's uremic pericarditis. Platelet dysfunction, so they can have elevated bleeding times, and if they start bleeding out, or confusion, which is just called uremia, and they would have asterixis with that. Those are the manifestations of uremia, and all of those are treated with dialysis. The top two causes of CKD are hypertension and diabetes mellitus. So remember, we're going to talk about other dialysis indications, and the mnemonic is AEIOU. So acidosis, which is refractory, electrolytes, hyperkalemia, that's also refractory, intoxications, overload, as in fluid overload from CKD, and uremia symptoms. So the intoxications, there's a submnemonic, which is MALE, which is methanol, aspirin, lithium, and ethylene glycol. Those four substances, when you're intoxicated with them, those are also dialyzable. So acute interstitial nephritis, I want you to remember NSAIDs, diuretics, and antibiotics. This is an allergic reaction to medications. The mnemonic is FEAR. Fever, eosinophilia, azotemia, meaning kidney injury, and rash. So when I think of acute interstitial nephritis, I think of someone who recently took drugs and now they have hematuria with white blood cell casts. Remember white blood cell casts you'll see in either acute interstitial nephritis or pyelonephritis. So when I see white blood cell casts, that kind of makes me suspicious right away. And then if they have a rash on top of that, it's a grand slam. This is acute interstitial nephritis. Versus acute tubular necrosis, which can be caused by hypoxia or toxins. When you are hypoxic or there's underperfusion to the kidneys, say that patient went into shock, so they had pre-renal azotemia. Remember, if the BUN creatinine ratio is greater than 20, that's pre-renal azotemia. If there's not enough blood flow reaching the kidneys, then the tubules can dry up and necrose, and that's called acute tubular necrosis. Certain toxins can do this as well, but the classic vignette is someone who went into shock and later developed acute kidney injury. And so the key here is on microscopic urinalysis, you will see muddy brown casts. And then this is just treated with IV fluids. Next is the renal tubular acidosis. So remember, when you have metabolic acidosis, the first thing you want to do is check whether the anion gap. Is this an anion gap metabolic acidosis or a non-anion gap metabolic acidosis? The anion gap, everyone knows the mnemonic: mud piles, methanol, uremia, DKA, propylene glycol, isoniazid, lactic acidosis, ethylene glycol, and salicylates. But non-anion gap metabolic acidoses, people tend to just get lost on it. But just keep it simple. The two most common causes of non-anion gap metabolic acidoses are diarrhea, because you poop out all the bicarb, so that makes you acidotic, or the next most common one is the RTAs, renal tubular acidosis. And it's not that hard. There's 3 types you need to know: RTA type 1, type 2, and type 4. So RTA type 1, number 1 should remind you of one letter, H. H should remind you of hydrogen. So type 1 is due to under-excretion of hydrogen. You lock up all the hydrogen, so you get acidotic. 1 should also remind you of stones. So kidney stones has the letter, you have to spell stone by spelling 1, S-T-O-N-E. So RTA type 1 is associated with kidney stones. Type 2 should remind you of bi, B-I. 2, bi, that's bicarb. You cannot absorb bicarb properly, so you lose a lot of bicarb. That makes you acidotic. Type 4, 4 letters, should remind you of ALDO, aldosterone. So this is hypoaldosterone. So hyponatremia, hyperkalemia. Remember, with aldosterone, it actually, people always remember you absorb sodium and excrete potassium, but people always forget that aldosterone action also excretes hydrogen as well through the alpha intercalated cells. And so when you lose all that hydrogen, you become alkalotic, but that's when aldosterone is working. But this is hypoaldosteronism, so all the hydrogen gets kept. So that makes you acidotic. And the key thing here is that's the only one that has hyperkalemia. So with those little kickers, that should help you. If there's kidney stones, non-anion gap metabolic acidosis, RTA type 1. If there's a non-anion gap metabolic acidosis with hyperkalemia, that's type 4. If it's neither of those, probably type 2. And then remember, if you have a metabolic alkalosis, what's the next best step? The next best step is to check the urine chloride. Why? Because if the chloride is high, right, the urine chloride is high, that means the kidneys are unable to absorb chloride, so this is a kidney problem. And if the urine chloride is low, then this is most likely another problem, a GI problem, such as vomiting. And you vomit out all the acids, so you get alkalotic. Remember that steatorrhea, so fatty stools, when it reaches the terminal ileum, this can bind up the calcium. This is also known as saponification. And when it binds up the calcium, remember that this is a cool concept because oxalate and calcium tend to bind at the terminal ileum, and then that makes it insoluble, so you poop it out, calcium oxalate. But if the fat is stealing all the calcium and binding to it, then oxalate has nothing to bind to and it's still soluble, so it gets reabsorbed and goes to the kidneys instead. When it goes to the kidneys, it finds another friend, it finds calcium in the tubules. So that will make calcium oxalate in the kidney tubules become insoluble and make kidney stones. So basically, eating high-fat foods predisposes to calcium oxalate kidney stones. Also, this is a tricky one too, is sometimes people will ask, with calcium oxalate stones, do you want to increase calcium uptake or decrease calcium uptake? Because people think, oh, calcium oxalate stones, oh, if you eat a lot of calcium, that'll make more calcium oxalate stones. That's not true. When you eat a lot of calcium, the calcium goes to the terminal ileum, same thing, it'll bind up all the oxalate, and then you'll be able to poop out all the calcium oxalate. If you have a low calcium diet, then that oxalate is free to go back and reabsorb back into the kidneys and make calcium oxalate stones there. So basically, my point is, if someone has kidney stones, you want to have a low salt diet, a low fat diet, and a high calcium diet. And also drink a lot of water to make the crystals more soluble. An elderly male who smokes a lot, who has gross, painless hematuria, I want you to think about two things. Either renal cell carcinoma or bladder cancer. Renal cell carcinoma, the person will also, on top of the hematuria, will also have flank pain and abdominal mass. If that's true, the next thing you want to do is a CT of the abdomen and then treat it with a nephrectomy. But if the person doesn't have an abdominal mass or flank pain, then the next thing you should think about is bladder cancer, and it's most likely transitional cell carcinoma. This is due to the carcinogens in cigarette smoke. The carcinogens are trapped in the urine a lot, and it tends to pool in the bladder, and that can cause cancer. And then if you suspect bladder cancer, which is gross, painless hematuria, in a chronic smoker without any signs of renal cell carcinoma, so no abdominal mass or flank pain, then the next best step is a cystoscopy. Next is a young male with irregularly shaped testicle, a painless mass in the testicle. What's the next best step? Is a scrotal ultrasound. You want to see if it's actually a mass. The mass could be a potential cancer. The next step is an inguinal orchiectomy. You don't want to biopsy it because of potential seeding of the scrotum. So if it's basically diagnosed on ultrasound and then you're just going to remove it. Testicular torsion versus epididymitis. They like to compare these. So remember that testicular torsion is when you get twisting around the spermatic cord and it cuts off the blood supply. This is an acute onset of severe testicular pain, but the spermatic cord is non-tender. If you elevate the scrotum, it's worse with elevation, and the key distinguishing factor here is the cremasteric reflex. If you stroke the medial aspect of the upper thigh, the scrotum under normal conditions will raise, but in this one, that reflex is absent, whereas in epididymitis, it's present. Another key distinction is epididymitis is an infection. So this person will also have fever, but their cord will be tender, and also upon elevation, it's relieved. So those are the differences. But if I had to remember the key differences, is epididymitis will have a fever, and then testicular torsion has no cremasteric reflex. And if you're unsure about the diagnosis of testicular torsion, like in the vignette, the picture is not very clear and they ask what's the best next step, then you want to do a scrotal ultrasound. Say there might be mixed features, but if it's very clear, the diagnosis is clear cut and there's no contradicting, and that's what I mean by clear cut. If all the facts are textbook, but if one of the facts kind of doesn't go with it, like maybe the patient has no cremasteric reflex, but they have a fever, and when you raise the scrotum, it's the pain is relieved, so there's contradictory information, then what they want you to know is what the next diagnostic test would be a scrotal ultrasound, a Doppler, to check for blood flow or to narrow the differentials. If it's very clear, then the next step is orchiopexy, so surgery. And you want to do bilateral orchiopexy because the other one will most likely TORS as well sometime in the future. Epididymitis is also, I want to compare and contrast that with orchiitis, right? Testicular inflammation of the testicles versus prostatitis. So the three of those are all can all get inflamed. And in a young person, the difference is between a young person and an old person. So a young person, the main culprits will be gonorrhea and chlamydia. And in an older person, the main culprit will be E. coli. So you treat them with different antibiotics. By young, it's like someone less than 35, and by older, like older than 35. And sexual history helps too. So a young person, you're going to give ceftriaxone and azithromycin, and an older person, you want to treat with a fluoroquinolone. All right, fluids, electrolytes. So the dreaded hyponatremia algorithm. So for hyponatremia, the first thing you want to do is check the osmolarity. So normal osmolarity is between 275 and 295. If they're mean, they won't give it to you. If they're nice, they'll give it to you. Well, if they're mean, you have to know how to calculate it. So it's 2 times sodium plus 1/18 glucose plus 1/3 BUN. That will give you the serum osmolarity. And you have to determine whether it's hyperosmolar, isotonic, or hypotonic. So above 295, in the middle, or below 275. If it's high, then this is most likely caused by glucose. If it's isotonic, then this is called pseudohyponatremia, and it's most likely caused by protein or lipids. If it's low, this is where the majority of them fall under. Then the next step is to check volume status. If they're hypervolemic, if they're euvolemic, or they're hypovolemic. And you can check by blood pressure and mucosa. If they're hypovolemic, they'll have dry mucosa and low blood pressure, and so on. So if they're hypervolemic, the main causes are CHF, cirrhosis, or nephrotic syndrome due to systemic edema, and that's fluid overload. And then if it's normal volume, the two most common are SIADH and primary polydipsia. And if they're hypovolemic, the most common causes are diarrhea, vomiting, or diuretics. So after you've determined the volume status, right, then you want to check the urine sodium, and the cutoff is 20. If it's above 20 or below 20, as a general rule, so the urine sodium is an indirect way of checking how good the kidneys are at absorbing sodium. So if the urine sodium is low, that means you're absorbing sodium well. It's kind of like FeNA. Remember FeNA? If it's greater than 2, then that's most likely intrinsic renal. But if it's less than 1, then that's most likely pre-renal. Same concept. So if the urine sodium is high, then this is an intrinsic kidney disease. Whereas if the urine sodium is low, then the sodium is able to be reabsorbed, so you know the kidneys are good. It's gotta be elsewhere. For example, let's start with if you are hypovolemic, right? Hypovolemic, hypotonic hyponatremia, and the urine sodium is high, then this is most likely diuretics. But if the urine sodium is low, then this could be diarrhea or vomiting. Then if they are euvolemic, right, hypotonic hyponatremia, you have to decide, is this SIADH or is this primary polydipsia? Well, SIADH, right, will have, since you're pulling in all the water, that will concentrate the sodium a lot, right? So sodium levels will be above 20, but primary polydipsia, it's dilute everywhere, even in the blood and the urine. So the urine sodium concentration will be really low. So the exception here is that in euvolemic hyponatremia, hypotonic hyponatremia, that one you kind of have to use your logic. So the last example would be like a hypervolemic hypotonic hyponatremia. If the urine sodium is above 20, then you know this is some sort of chronic kidney disease or acute kidney injury like acute tubular necrosis. But if the urine sodium is below 20, then think CHF, cirrhosis, or nephrotic syndrome. But as a general, and then the next thing is why it's important to diagnose this is it's important to also know how to treat these cases of hyponatremia. And I'll try to make it as simple as possible. And for hyponatremia, it goes like this: hypervolemic or euvolemic without symptoms, hypovolemic without symptoms, or hypovolemic with symptoms. If they're hypervolemic or euvolemic without symptoms, the first thing you want to do is water restriction. If they're hypovolemic and they have no symptoms, then the next thing you want to do is normal saline. If they're hypovolemic with symptoms, or if their sodium levels are below 120, which is severe hyponatremia, this is where you give hypertonic saline, which is 3%. So symptoms of severe hyponatremia would be like lethargy and like coma or like altered mental status. Then for hypernatremia, the algorithm goes like this. It's either euvolemic or hypervolemic, right? Hypovolemic, again, without symptoms, or hypovolemic with symptoms. And so if the way I think about this is if someone has hypernatremia, you want to water it down, right? But the problem is when you're watering down hypernatremia, you have to do it very gradually because remember, high to low, the brains will blow. So if someone has hypervolemia or euvolemia, right, their fluid total body water is already like up to the brim, right? And their blood is very salty. So you want to give basically free water because there's such a small amount of fluid volume left that you want to make as much of an impact as possible to water down that salt. So free water. But if they are hypovolemic, right, with no symptoms, then basically you want to give D5 half normal saline. And that's because, just think of it in terms of gradients of the fluid replacement from being least salty to most salty, right? So hypovolemic with no symptoms, right, which is the middle one, is you're gonna give half normal saline. And the reason why your fluid has a little bit more salt is because you need to replace more volume, and because there's so much volume you need to replace, it needs to be more gradual. Could you imagine if you filled this much up with only water? Then that could be really dangerous. You could overshoot. So that's why you want to be more gentle with half normal saline. Versus the most severe form, which is if they're hypovolemic with symptoms, then that one is where you give completely normal saline. So half is around 0.45% saline, right? But normal saline is 0.9. So this is the saltiest of the three options. And so this one, if they have symptoms, you want to be able to give normal saline, which gives the most room to add as much fluid as possible while being as gentle as possible. So to recap, if you're hypervolemic or euvolemic, right, you want to just give free water. If you're hypovolemic without symptoms, then half normal saline. If you are hypovolemic with symptoms, the most severe one, then that's when you give normal saline. So remember that blood transfusions can cause hypocalcemia because the citrate in the packet will bind up all the calcium. And then this is a classic high yield too, is treatment of hypercalcemia. The first step is IV fluids. Treatment of hyperkalemia, the first thing you want to do is look at the EKG. If there's EKG changes, you want to give calcium gluconate. That helps stabilize the cardiac membranes and helps prevent arrhythmias. You can also give insulin, which pushes potassium into the cell, but make sure to give glucose with it to keep yourself euglycemic. And Kayexalate also helps too, which binds potassium in the gut and helps promote excretion of potassium. So hypermagnesemia, the first sign of hypermagnesemia is loss of deep tendon reflexes, and you treat it with IV calcium gluconate, which also stabilizes the cardiac membranes. Next is the parathyroid hormone axis. So remember that primary hyperparathyroidism, increased PTH, so first, parathyroid hormone has three actions. One is it works on the bones directly, which increases calcium and phosphate release from the bone. The second thing it does is it will work on the kidney tubules itself, and that will help increase calcium absorption and promote phosphate excretion. So increase calcium, decrease phosphate. The last action of parathyroid hormone is it works on helping convert calcidiol to calcitriol. And then calcitriol, which is vitamin D3, will then go to the gut, and that helps increase calcium and phosphate uptake. And then you all three sites have different pluses and minuses, but at the end of the day, when you total it all up, the final balance is that high parathyroid hormone causes hypercalcemia and hypophosphatemia. So high PTH, high calcium, low phosphate. You treat hyperparathyroidism, primary hyperparathyroidism, with a parathyroidectomy. Also, the PTH axis is there's a feedback loop too. And the two things that close the loop that cause negative feedback are high calcium levels and high vitamin D3 levels. So if vitamin D3 is high, boom, PTH will shut down. If calcium is high, boom, PTH will shut down as well. So this hormone axis is difficult, but once you get the hang of it, it's pretty fun. So next would be another scenario would be hypoparathyroidism. So low PTH will mean low calcium and high phosphate. Another situation is kidney failure. So if someone has kidney failure, this is getting more tricky. You have to remember that they're no longer able to convert calcidiol to calcitriol because that's one of the main functions of the kidney. So they aren't able to absorb calcium and phosphate from the gut. Also, the kidney tubules don't work, so they have low calcium. They can't absorb calcium, but they can't dump phosphate either. So phosphate will be locked up in the body, and then basically actions on the bone will try to increase phosphate and calcium. But at the end of the day, when you total everything all up, kidney failure will result in elevated PTH, but low calcium and high phosphate. Why? Because the phosphate is unable to be excreted and the PTH levels aren't high enough to overcome the deficiencies of the kidney and the gut from absorbing calcium. Kidney failure will be high PTH, low calcium, high phosphate. And then there's vitamin D deficiency, which can be just an isolated problem, which can be due to nutritional deficiencies or malabsorption, like in celiac disease or people with pancreatic cancer or cystic fibrosis or sunlight deficiency. These people will have low vitamin D3, and then because of that, they won't be able to absorb calcium and phosphorus from the gut, and then these people will have a total of low calcium, low phosphorus, and high PTH, because when they have low calcium and low phosphorus, the PTH will turn on, and then it'll try to absorb more calcium, but it'll also dump out more PTH. So PTH will go even lower. And then remember that the main source of increasing calcium levels is the gut. So basically, people who have vitamin D deficiency will have low everything, and then the PTH will turn on to try and compensate for that, but it'll usually still stay very low. The last is squamous cell cancer of the lung. Remember, it can make PTHRP, parathyroid hormone releasing related peptide, and then this acts exactly the same like parathyroid hormone. So it'll increase calcium and decrease phosphate. And then remember, since the calcium levels will be so high all the time, that will feed back on the actual PTH, and then the actual PTH levels will be low. So this will cause high calcium, low phosphate, low PTH, and high PTHRP. So remember, for mechanical ventilation settings, PCO2 is controlled by tidal volume and respiratory rate, whereas PaO2 is determined by FiO2 and PEEP. So basically, a patient who's mechanically ventilated, they'll give you the ABGs, they'll give you the pH, if it's alkalotic or acidotic, and they'll give you the PCO2 and the PaO2, and then you have to know what kind of adjustments to make. Like, if the PCO2 is too high, right, so they're hypoventilating, then you want to increase ventilation, and the parameters you can change are tidal volume or respiratory rate. So if you increase both of those, the patient will blow out CO2 more. and vice versa. Whereas if they have hypoxemia, low PaO2, then you can increase PEEP or FiO2 to help increase the oxygen levels, and vice versa. That's a classic question they like to ask too. So in summary, acid base, first thing you want to do is check the pH. If it's between 7.35 and 4.5, that's normal. Below that is acidotic. Above that is alkalotic. That's the first step. The second step is to look at CO2 and bicarb. So CO2 is normal between 35 to 45, and bicarb is normal from 22 to 28. And then remember that low bicarb equals acidosis, high bicarb equals alkalosis. Low CO2 equals alkalosis, high CO2 equals acidosis. So the first thing, look at the pH. If it's low, you know it's an acidosis. You have to determine what is the culprit. It can either be bicarb or CO2. One of them will be in the range that will be acidotic or will be acidotic. If it's high CO2, boom, you got it. It's the first thing is it's a respiratory acidosis. Look at the bicarb next, right? And determine, and then the bicarb is the metabolic side of the pH, right? There's a respiratory arm, which is the CO2, and then the metabolic arm, which is based on bicarb. And then you determine whether that's acidotic or alkalotic. If it's acidotic, then that's mixed respiratory acidosis and metabolic acidosis. If it's alkalotic, then you know that's compensation because it disagrees with the pH. That's kind of just a rough overview of how to calculate acid base, but say you have to know the next best step. So if you calculate a metabolic acidosis, which means a pH below 7.35, right, and a bicarb that is below 22, right, the next best step is to calculate the anion gap. Sodium minus chloride minus bicarb. If it's greater than 16, right, then that's an anion gap metabolic acidosis. Then you think of your mud piles mnemonic. If it's below that, it's non-anion gap, and the two most common causes are RTA or diarrhea. And then RTA can be 1, 2, or 4, which I talked about earlier. And then the next is metabolic alkalosis. So if it's metabolic alkalosis, which means that the pH is above 7.45 and the bicarb is above 28, then the next best step is you want to check the urine chloride. If the urine chloride is high, above 20, then this is a renal problem. If it's low, then this will be a GI problem. And then remember that if you want to get more detailed, if someone has a metabolic acidosis that's non-anion gap, how can you tell if this is a RTA problem or a diarrhea? Is you can calculate the urine anion gap. So basically that's sodium plus potassium minus chloride. If it is negative, right, GUT, then this is a GI loss. If it's positive, then that is a kidney loss, so most likely renal tubular acidosis. And that is electrolytes. So anemia, next best step is calculate reticulocyte count or MCV. Helps you narrow down your differential. Increased reticulocyte count would be like 2% or more. That means that the baby red blood cells are being pushed out like crazy to replenish the blood cells that have been dying. So that either indicates hemolysis or like splenic sequestration. And then the MCV can help you decide whether it's microcytic, normocytic, or macrocytic. The microcytics would be like fast, right? Iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, or thalassemia. The normocytics there's a lot of differentials for that. And then the macrocytics could be most commonly folate deficiency, or B12 deficiency, cyanocobalamin deficiency. And to tell the difference between the two, well, B12 usually has neurologic problems called subacute combined degeneration, which is a problem of the dorsal column and the upper motor neurons, the corticospinal tract. On top of that, blood markers, B12 will have an increased methylmalonic acid, whereas B9 doesn't. And then other causes of, but then this is megaloblastic anemia, right? So that means macrocytic anemia plus hypersegmented neutrophils, whereas macrocytic anemias, not necessarily megaloblastic, will have an MCV of greater than 100. The red blood cell MCV is greater than 100, but they don't have hypersegmented neutrophils, and the most common ones would be alcoholics. Or some two more zebra ones would be Fanconi's anemia and Diamond-Blackfan anemia. So Fanconi's anemia is the one where you have a hypoplastic thumb and pancytopenia, whereas Diamond-Blackfan anemia is the triphalangeal thumb with just anemia. So the next thing is red blood cell transfusions. I want you to remember timing here. Timing here is critical. So 30 seconds, 30 minutes, 3 hours, 3 days. If a red blood cell transfusion problem happens within 30 seconds, it's anaphylaxis, and this is due to an IgA deficiency. How you prevent this is by washing the blood. The next is 30 minutes. This is ABO incompatibility. This is an acute hemolytic reaction. The signs I want you to look for that make it different than the others is hypotension and flank pain. You treat this with IV fluids. At 3 hours, this is where you get a febrile reaction, and this is due to cytokine release, and you prevent this with leukoreduction. And then 3 days later is where you get the delayed hemolytic reaction. This causes jaundice a few days later, and the treatment is it's self-limited, so just let it pass. So timing is clutch for the red blood cell transfusions, and obviously it can vary a little bit, but it's generally like plus or minus, like within that range. You want to think in terms of seconds, minutes, hours, days. So other key things here is a high red cell distribution width is really helpful in the microcytic anemias, because a high RDW plus some microcytic anemia is most likely iron deficiency anemia, whereas the other microcytic anemias don't do that. Like thalassemia will have normal RDW. Another one that's helpful is high MCHC is usually associated with hereditary spherocytosis. Remember, that's the congenital red blood cell disease where you have the missing ankyrin and spectrin, which prevents the red blood cell from keeping the normal biconcave shape, and then it makes the spherocytes. And then these can get lodged in the spleen, and you can treat that with a splenectomy. Beta thalassemia is associated with Mediterranean populations. You'll see the crew cut skull on x-ray, and it has an elevated hemoglobin A2, whereas alpha thalassemia is associated with Asians, and this will also have a microcytic anemia as well. So in these thalassemia vignettes, look for race being introduced into the vignettes. Remember, sideroblastic anemia versus hemochromatosis, they can have very similar iron studies. So the difference is that, so sideroblastic, so they both have high ferritin, high serum iron, and low TIBC, but sideroblastic anemia is basically iron in the red blood cells bursting out of the RBCs. So this is caused by B6 deficiency or lead poisoning or isoniazide, which prevents the incorporation of iron into the hemoglobin. And then versus hemochromatosis, which is autosomal dominant, caused by excessive iron absorption through the gut. And then this is actually iron, so much iron that it starts out in the red in the circulatory system and then ends up flooding into the red blood cells as well. And then these both have similar markers. But the kicker is that hemochromatosis will also have the additional symptoms of iron overload, such as bronze diabetes and elevated LFTs. Remember, hemochromatosis is treated with phlebotomy, which helps remove the excess iron. Anemia of chronic disease can be a normocytic anemia or a microcytic anemia, and this is due to any type of chronic disease or inflammation. And when this happens, the cytokines will suppress erythropoiesis and also lock in the precious iron in the red blood cells and the rest of the human cells to basically hide it away from potential bacteria. And this person will have high ferritin, low serum iron, and low TIBC. Remember, most of the time, ferritin and TIBC is also known as transferrin, they usually are opposite. So if ferritin's high, TIBC will be low. For example, let's try iron deficiency anemia, right? So iron deficiency anemia, and ferritin is a reflection of iron within the cells. So say iron deficiency anemia, you don't have iron anywhere in the body, so ferritin will be low, right? Transferrin or TIBC will be high, and then the third one you have to think about is serum iron. Since it's iron deficient, then serum iron will be low. And then and it kind of just works like that. And then remember, anemia of chronic disease is treated by treating the underlying disease. So if someone with rheumatoid arthritis has anemia of chronic disease, right? So high ferritin, low serum iron, low transferrin. What's the best next treatment? A, B, C, methotrexate, D, E. Well, it's methotrexate. Why? Because you're treating the underlying disease. And remember, key terminology differences: aplastic crisis and aplastic anemia are not the same thing. Aplastic crisis is red blood cells only, whereas aplastic anemia is kind of a misnomer. It's actually a pancytopenia. What can cause aplastic crisis? It's a virus. It starts with the P, it ends with the parvovirus. Parvovirus in the mom can cause this problem in the fetus. The answer is hydrops fetalis. So spherocytes you'll see in two cases: hereditary spherocytosis or autoimmune hemolytic anemia. And the reason why in autoimmune hemolytic anemia you get spherocytes is because the antibodies will pluck off membrane blebs, and then that will basically diminish the redundant plasma membrane, and then instead of having enough plasma membrane to make a biconcave disc, it now just becomes a round shape. And then remember, autoimmune hemolytic anemia, you have two types: warm and cold. So warm is great. Great stands for IgG. So this is an IgG antibody against the red blood cells. And the main ones are lukewarm. L stands for leukemias, lymphomas, and lupus. These can cause warm autoimmune hemolytic anemias. This causes splenic sequestration, and so you'll have splenomegaly and warm autoimmune hemolytic anemia, and you treat this by treating with steroids. And then cold autoimmune hemolytic anemia is cold is miserable. M stands for IgM, so this is an IgM antibody against the red blood cells. And M also stands for mycoplasma or mono, and you get hepatomegaly in this case, and you treat this with avoiding the cold. So TTP is thrombotic thrombocytopenic purpura. This is due to excess von Willebrand's factor. So you need to remember Adams TS13. It's a protease that breaks down that basically cleaves von Willebrand factor and makes it inactive. When you have a lack of this, now von Willebrand factor is just there's way too much of it everywhere. And remember, von Willebrand factor attaches to GP1B, which is part of the platelet that causes platelet adhesion. So it allows for the platelet to stick to the endothelium. And then, so you'll have excessive platelet adhesion, and then these will all clump up. And then when the red blood cells swim by, there's all these like speed bumps everywhere, but in a very narrow pipe. And then the red blood cells will shear. This is called a schistocyte. But by shearing, they also hemolyze, and so that's anemia, hemolytic anemia. So then you'll have thrombocytopenia due to the platelet consumption and hemolytic anemia. So that's thrombocytopenic purpura. But it also causes fever and renal problems and encephalopathy. So there's a mnemonic, which is FAT-RN: fever, anemia, thrombocytopenia, renal problems, and neuro problems. And then a variation of this is called hemolytic uremic syndrome, which is caused by EHEC. EHEC is a type of E. coli, enterohemorrhagic E. coli, which is caused by eating undercooked burger patties, and that can also cause a microangiopathic hemolytic anemia, which is a fancy word of saying what I just described earlier with the platelet clumping and the schistocytes. And that is anemia, thrombocytopenia, and renal problems. And remember, that is one of the manifestations of uremia, so you want to treat that with dialysis. And then there is HIT, which is heparin-induced thrombocytopenia. So sometimes this patient will have a antiplatelet factor 4 antibody, and because of this, when you give them heparin, then what will happen is that these antibodies will start taking out your platelets. So the vignette will be a person who has taken heparin, and they'll show you day 1 labs, and it'll be like 150,000 platelets. And on day 7, now they have 80,000 platelets. What to do next? The classic question. And the classic answer is stop heparin and start dabigatran or argatroban, which are direct thrombin inhibitors. And remember that even though they have thrombocytopenia, these platelets clump up, so they become prothrombotic, so they're at increased risk for DVT and PEs. You can also diagnose HIT with a serotonin release assay. Next is von Willebrand's disease. Von Willebrand's disease is due to a deficiency of von Willebrand or non-functioning von Willebrand factor, and you will see a reduced ristocetin activity, which means, well, ristocetin is a lab test that induces von Willebrand factor from binding to glycoprotein 1b on the platelets, and that will cause coagulation. But if someone has von Willebrand's disease, then the von Willebrand factor won't bind to the GP1B, and this will not coagulate. So if it doesn't coagulate, then that's a diagnosis of von Willebrand's disease. Also, remember, von Willebrand factor carries factor 8 with it, so you will see an elevated bleeding time and elevated PTT. Why? Because PTT helps. PTT is a measure of the intrinsic factor, the intrinsic pathway, which factor 8 belongs to. Remember, factor 12, 11, 9, 8, and 10 are intrinsic, and extrinsic is factor 7. The extrinsic pathway is measured by warfarin, which includes factor 7. And then bleeding time is a measure of platelet activity. So since there's no von Willebrand factor, then the platelets don't stick, so bleeding time will be elevated. So a patient with von Willebrand disease will have elevated PTT, elevated BT, ristocetin assay that has no activity, no clumping, and clinical signs. It will be usually a person who has epistaxis with gingival bleeding and menorrhagia. For some reason, a lot of these questions, it's in a female. And you can treat this by desmopressin. Desmopressin, remember, is a synthetic vasopressin, aka ADH. And ADH not only works on the kidneys, but it works on the endothelial cells too, which helps promote the release of von Willebrand factor. Last is DIC. DIC is the most extreme version of a microangiopathic hemolytic anemia. And so you'll have the thrombocytopenia from clumping, consumption of that, with the schistocyte hemolysis, so you get anemia with that too. But on top of that, what makes it different than TTP and HUS is that it also consumes coagulation factors. So then this person will also have elevated PT, elevated PTT as well. So all their coagulation timing markers will be increased. And then DIC patients will also be spontaneously bleeding from different sites like IV access sites, and they might also be in shock. Oncologic emergencies are hypercalcemia, treat with IV fluids. Spinal cord compression from metastasis, treat with steroids. Cardiac tamponade, pericardiocentesis. Tumor lysis syndrome, IV fluids. Remember, Hodgkin lymphoma versus non-Hodgkin lymphoma, they can both cause B symptoms, fever, night sweats, weight loss. That can also be seen in TB. But Hodgkin versus non-Hodgkin, remember, Hodgkin has the Reed-Sternberg cells, whereas non-Hodgkin does not. Hodgkin also has lymph nodes that it tends to cluster together in chains, whereas non-Hodgkin can be lymph nodes that are spread out. The most common Hodgkin lymphoma is the nodular sclerosing type and the lymphocyte depleted, whereas non-Hodgkin is the ones where you will see Burkitt, follicular, and HIV lymphoma. And then any lymph node that's 1 centimeter plus that's not associated with an infection, non-painful, and has been there for over a month, you should biopsy it. You have ALL, AML, CML, CLL, and then the acute ones are due to increased blasts, more than 20% blasts, and then the chronic ones are more the mature types that are elevated, and then the M and L designations tells you which of the blood cells are elevated. So M stands for myelogenous, so that's anything other than the lymphocytes, whereas L is lymphocyte. So myelogenous, think of like increased basophils, eosinophils, neutrophils, and then the L1 stands for lymphocytes. And then AML will have the Auer rods, and then CML, remember that this one, the chronic ones tend to have more reliable blood markers. They'll have super elevated white blood cell counts, but the acute leukemias will tend to have pancytopenias, and the blood cell counts aren't as reliable, but the chronic ones will definitely have elevated leukocyte counts. And then how do you know if it's CML versus CLL? Well, myelogenous, when they show you the breakdown of white blood cells, like, neutrophils, lymphocytes, monocytes, eosinophils, basophils, well, the basophil count will be super high. And remember, CML, you treat it with imatinib, which is a tyrosine kinase inhibitor, and usually these people will have a pretty good prognosis if they're adherent to these medications. And so that's a pretty cool breakthrough. And then remember that CML will have a low lab score, and a lab score is a reflection of normal leukocyte function, versus polycythemia vera, which is a red blood cell cancer. So they have super elevated hemoglobin, but they might also have super elevated white blood cells and platelets too. But so anytime you see polycythemia, remember what the best next step is to check erythropoietin levels, because if the erythropoietin levels are low, this is polycythemia, but if it's elevated, that means this is a secondary reactive polycythemia. So certain things that can cause elevated hemoglobin can be like causes of hypoxia or hypoxemia. So remember, erythropoietin is generated from the interstitial cells of the kidney. So if the kidney is not getting enough oxygen, for example, I don't know, any type of chronic lung disease or obstructive sleep apnea, then the erythropoietin levels will go up and then try to generate more red blood cells to increase and improve oxygen delivery. Polycythemia vera is associated with the person who gets pruritus after hot showers. That's basically it for hemonc. So typical pneumonia, the three main bugs need to know: strep pneumo, H flu, Moraxella. Atypical, Mycoplasma, Chlamydia, and Legionella. Hospital acquired or nosocomial acquired are E. coli, Pseudomonas, and Staph aureus. Remember, typical lobar consolidation, atypical interstitial infiltrates, and hospital, especially if it's mechanical ventilation, this can predispose to aspiration pneumonia, which will usually be in the right lower lobe, and you might see some air fluid levels that indicate abscess formation. Famous antibiotics, you need to know the difference between, for pneumonia, outpatient versus inpatient. So outpatient, if it's typical pneumonia, amoxicillin. If it's atypical pneumonia, azithromycin. Inpatient, most common will be a fluoroquinolone. Aspiration pneumonia, then it'll most likely be clindamycin to cover for anaerobes. And then if it's hospital-acquired pneumonia, you want to cover for Pseudomonas. So this is, you want to use Zosyn, which is piperacillin tazobactam, or cefepime, which also covers Pseudomonas. So the PPD skin test. A positive test, it really just depends on the demographic you're part of. A healthy person, 15 millimeters or more is positive. For 10 millimeters or more, it's positive if you are someone who's been incarcerated, or if you're a healthcare worker, or if you're a foreigner. If it's greater than 5 millimeters, it's positive if you have HIV, or if you've been in close contact with someone who's known to have TB. If the PPD test, the wheal, is positive, depending on what group you're in, say I'm a medical student or a physician and my wheal is 11 millimeters, that's positive. What's the next step? The next step is a chest x-ray. So the chest x-ray can either be positive findings or it can be clear. If it's positive findings, then you're gonna see a bunch of stuff in the upper lobes, cavitations. I'll probably also have symptoms such as fever, night sweats, weight loss, hemoptysis. If it's positive, then I will be treated with the RIPE regimen, which is rifampin, isoniazid. Make sure to give B6 with it. Why? Because if I don't give B6 with isoniazid, it can cause neuropathies. And then P is pyrazinamide and E is ethambutol. You're gonna give the 4 of those for 2 months, and then after 2 months, you're gonna give rifampin and isoniazid for additional 4 months. But then if it's a negative chest x-ray and it's clear, then you treat with isoniazid for 9 months. Someone might ask, hey, but what if I got the BCG vaccine? Well, it doesn't matter. If you've gotten the BCG vaccine and you have a positive wheal, you still do a chest x-ray. If the chest x-ray is negative, you still do isoniazid for 9 months. All TB meds can cause hepatotoxicity. You stop only if the LFTs are greater than 3 times normal. Pyrazinamide, classic side effect is it can cause gout, and ethambutol, the classic side effect is it can cause eye problems. Rifampin can cause the orange sweat and orange tears, which can look like blood, and isoniazid can cause neuropathies and hepatitis. So next is meningitis. Meningitis, you have to know about the ages. Less than 3 months, everybody in between, and greater than 50 years old. So the general population, the most common are strep pneumo, H flu, and Neisseria meningitis. Neisseria meningitis will cause a rash as well. If they're less than 3 months old, you have to consider a different set of bugs, which is group B strep, E. coli, and Listeria. It spells out Bell. And then those kids who have so you want to treat meningitis empirically, right? So because the cultures can take a while to come back and the effects can be devastating, so you want to start treatment as soon as possible. For your normal population, which is strep pneumo, H flu, and Neisseria, then you want to treat empirically with vancomycin and ceftriaxone. Vancomycin will cover the strep, and ceftriaxone will cover the Neisseria. But then if it's less than 3 months old, you want to cover for Listeria, so you want to add ampicillin. And this happens as well for adults who are greater than 50 or immunocompromised. You also want to add ampicillin. Remember, meningitis presents with headache, fever, nuchal rigidity, photophobia, and it will also have the Brudzinski sign, which is when you flex the neck, it can cause hip flexion to reduce tension in the spinal cord. And then remember that the CSF findings, right? So you can have viral, something that indicates viral, something that indicates bacterial, or something that indicates fungal. Fungal is usually more immunocompromised, like AIDS patients, and that will be more like Cryptococcus neoformans, which will have the India ink positive stain. And that's treated with amphotericin. But my point is, you need to know the CSF markers. All of them will have increased WBCs, and most of them will have increased protein. But the key here is look at what type of WBCs are elevated, and is the glucose low or normal. So bacterial, neutrophil predominant, glucose is low. Why? Bacteria consumes glucose. Viral is the lymphocyte predominant, glucose is normal. Viruses don't consume glucose. Fungal, kind of in between both. Lymphocyte predominant with decreased glucose. And then the most common viral meningitises are herpes, echovirus, or enterovirus. One exception is TB, although a bacteria can look like a fungus. But then TB will have the basilar enhancement. And another key thing is herpes will tend to go after the temporal lobes and have seizures, and the lumbar puncture will also have blood. A UTI is usually treated empirically without a urinalysis, and the treatments are, the first line treatments are TMP-SMX, nitrofurantoin, and fluoroquinolones. If they're pregnant, then you want to treat with a different set of antibiotics. Nitrofurantoin works as well, but you can also use amoxicillin or cephalosporins. Sometimes there's something called a complicated UTI, and in that case, you want to do a urine culture, and that happens in 4 demographics. One is diabetics with the UTI, the second is pregnant people, the third is a male with a UTI, and the fourth is an immunosuppressed patient. If someone has greater than 2 UTIs per year, that's not good, so you want to give them TMP-SMX prophylaxis. And also, they can either take it prophylactically every day, or they can take it as a post-coital prophylaxis. Again, prostatitis, epididymitis, or orchitis depends on the age. If it's young, most likely gonorrhea and chlamydia. If it's old, most likely E. coli. So the young patients treat with ceftriaxone, azithromycin. The old people treat with fluoroquinolones. HIV, you do a C-section if the viral load is greater than 1,000. If it's below that, it's fine, you can deliver vaginally. Remember, HIV, contraindication to breastfeeding. The prodrome, very similar to mono, sore throat, malaise, fever, lymphadenopathy, but the kicker is they'll have a rash, possibly diarrhea. And then remember, prophylaxis starts at CD4 200 or less, TMP-SMX, which prevents pneumocystis jirovecii. Once the CD4 drops to below 50, then you prophylax with azithromycin, which covers for Mycobacterium avium complex, which causes fever, diarrhea, and weight loss. Another complication of AIDS or HIV is Cryptococcus meningitis, which is treated with amphotericin, and it's associated with pigeon exposure. And then CMV can cause colitis, esophagitis, retinitis, and bloody diarrhea. So AIDS, think of 3 types of diarrhea: cryptosporidium, CMV, and MAC. Cryptosporidium will be a lot of watery diarrhea, whereas CMV will be bloody diarrhea, and then MAC will be fever plus diarrhea. People with HIV get 3 vaccines: pneumovax, influenza, and Hep B. You should know the difference between lymphogranuloma venereum, which is a type of chlamydia, L1 to L3, versus granuloma inguinale. They both have genital ulcers plus inguinal lymphadenopathy, but lymphogranuloma venereum has the buboes, so big, painful, hard, red inguinal nodes, whereas granuloma inguinale, the nodes actually ulcerate and turn into granulomas. And then they both are painless ulcers. Remember, the painful genital ulcers will be either HSV or chancroid, which is Haemophilus ducreyi. Primary syphilis first starts with this painless chancre, right? Then secondary palms, rash on the palms, plus the condyloma lata over the genitals. Then you can have the late phase, which presents with gummas, which are granulomas, tabes dorsalis, which affects the dorsal columns exclusively, and syphilic aortitis, and also meningitis. Common bugs: cellulitis, most likely Strep pyogenes. Erysipelas, also Strep pyogenes. The difference between the two: erysipelas has a rapid onset, whereas cellulitis is more gradual. Erysipelas also has clear, distinct borders, whereas cellulitis does not. And then an abscess, you want to think about Staph aureus. And then necrotizing fasciitis, the 2 common ones are Strep pyogenes or Clostridium perfringens. They both have pain out of proportion. So it'll be erythematous and red. It advances pretty quickly, but when you barely touch it, they'll be screaming in pain. And then the difference between the two, the most common is Strep pyogenes, but if there are gas bubbles or gas gangrene, then it's Clostridium perfringens. So for the tetanus algorithm, the things I want you to think about is ask yourself, greater than 3 vaccines or less than 3 vaccines in their life? Clean wound or dirty wound? So first, if they've had greater than 3 vaccines in their life, if it's clean, so clean means, superficial, no dirt in it, not very deep. If it's been greater than 10 years since their last booster, give the vaccine. Other than that, leave it alone. If it's a dirty wound, so like deep or dirty, then if it's been greater than 5 years, then only do give the vaccine. For people who have had less than 3 tetanus vaccines their whole life, or their vaccination status is unknown, first, is it clean or is it dirty? If it's clean, then you give the vaccine only. If it's dirty, then you give the vaccine and antibody. And that's basically it for tetanus. If they have tetany, you can add diazepam to minimize the muscle spasms. Septic arthritis and osteomyelitis, you should know the common bugs, and they're the same for both groups, luckily. So the normal person, it'll be Staph aureus, but the person who has sickle cell, it'll be Salmonella, and the IV drug user will be Pseudomonas. Remember, any swollen, painful, red joint, the next best step is to aspirate or do arthrocentesis for analysis, because we fear septic arthritis. Signs of septic arthritis would be fever, leukocytosis, and inability to bear weight on the joint or move it at all. That's a sign of septic arthritis. Usually the aspiration will show greater than 50,000 white blood cells. So Lyme disease, remember, starts with the target rash called erythema migrans. The first thing you want to do is determine what kind of treatment you want to treat with. And if it's person older than 8 years old, then doxycycline. But the trick question they love to ask is a kid with Lyme disease less than 8 years old, so a 6-year-old with erythema migrans, what's the treatment? A, doxycycline, or B, amoxicillin? It's B, amoxicillin. Why? Because doxycycline is a tetracycline, and tetracyclines can cause teeth discoloration, which isn't good for a little kid. And then malaria, you have 3 flavors: Plasmodium falciparum, Plasmodium vivax and ovale, or Plasmodium malariae. And to know which one is which depends on the timing of the fevers. So falciparum has a constant fever, Vivax ovale has a fever every 2 days, and malariae has a fever every 3 days. So any vignette where the patient has cyclic fevers, think of malaria. Also in the vignette, they'll have recent travel to a country such as India or a continent such as Africa. The treatment generally is mefloquine, but for Vivax and ovale, you want to add primaquine too, which will kill the hypnozoites in the liver. Treatment of rabies is irrigate the wound, plus give antibodies, plus the vaccine. And remember, it presents with hydrophobia and encephalopathy, and they will be really afraid to drink water. The problem is, at that stage, it's too late and most likely fatal. And rabies is most often caused by exposures to bats and getting bitten by a bat. Cat scratch disease is caused by Bartonella henselae. The classic presentation is a distal cat scratch with a proximal lymphadenitis, and you treat this with macrolide or doxycycline. Aspergillus, 3 flavors: ABPA, allergic bronchopulmonary aspergillus, aspergilloma, or invasive aspergillus. So allergic bronchopulmonary aspergillus, think of asthma and eosinophilia. The aspergilloma, think of hemoptysis with a chronic cough. On chest x-ray, there's a fungus ball in the upper lobe. Invasive aspergillus, very systemic, so fever, leukocytosis, hemoptysis with the classic halo sign, which is pulmonary nodule with the surrounding ground glass opacity, and this is treated with amphotericin. Dimorphic fungi, the mnemonic His-Cock blast spores, so histoplasma, coccidioides, blastomyces, and sporothrix. So histoplasma associated with bats and caves. This one, I want you to remember bilateral hilar adenopathy. A lot of these dimorphic fungi can have presentations that can be confusing. It can seem like almost like TB with the fever, night sweats, weight loss, and possible hemoptysis. But the kicker here is you should be suspicious that they're trying to get at a dimorphic fungi, because they'll usually talk about locations. Like for example, blastomyces is called Chicago disease. So you'll see a person who's from the Midwest. They'll mention specifically someone who's from like Iowa or Illinois. And then versus coccidioides is more like on the West Coast. So like someone from like Arizona or California. So look for location. And then blastomyces, I want you to remember purple skin lesions with pneumonia. That's blastomyces plus Midwest. Coccidioides, West Coast with respiratory symptoms and unilateral hilar adenopathy. Sporothrix, this is the person who gets their hand cut by a thorn, and then they have the lymphadenitis that follows a trail up their arm, and then this is treated with itraconazole or potassium iodide, or you can just watch Sketchy Micro. Cryptosporidium, this is HIV with severe watery diarrhea. So the hookworms, you have, spells out sand, strongyloides, ancylostoma, necator. These all go in through your feet, goes up to your lungs, you cough it out, and then you swallow it. It ends up in your GI system. The thing about these parasites and worms is look for eosinophilia, because worms, parasites, anything foreign like that, the eosinophils go up because they have a weapon called major basic protein, which helps lice, worms, and parasites. Enterobius vermicularis, remember the anal worms on a young kid. Scotch tape test shows a lot of baby worms, and you treat with mebendazole. Tapeworm, think about food sources. T. solium is from pork, D. latum is from fish, and T. saginae is from beef. You want to treat this with praziquantel. Schistosoma, this is the snail. Think of a person from the Middle East who has hematuria with eosinophilia. Toxic shock syndrome, think shock plus someone who has had a nosebleed and has kept some sort of paper up their nose for a while, or tampon that has been in there for a while. And then this person will have desquamation as well. The Staph aureus exotoxin is hyperactivating the T cells, which release a lot of cytokines, which causes you to go into shock. So treat with IV fluids and vancomycin. Neutropenia is an absolute neutrophil count of less than 1,500. High yield to no. Neutropenic fever is you treat empirically, and that it's the culprit is Pseudomonas until proven otherwise. So you want to treat with Zosyn, which would cover Pseudomonas, and Zosyn is the brand name for piperacillin tazobactam, but it's easier just to say Zosyn. Gastroenteritis can be bloody or watery. The most common watery ones are rotavirus, norovirus, or ETEC if they had recent travel to somewhere like South America. But the bloody ones can be Campylobacter, EHEC, Salmonella, Shigella, and Yersinia. Those are the common ones. They will be febrile and have bloody diarrhea. And the question is, what's the best next step? And the best next step is stool analysis for white blood cells. What if the white blood cells come back as positive? Then the next best step is stool culture. Most bloody diarrheas are treated symptomatically. You only give antibiotics if they're really young, really old, or immunosuppressed. A definite no-no is don't give antibiotics for EHEC, which predisposes to hemolytic uremic syndrome. Someone who takes antibiotics and then develops diarrhea afterwards, think C. diff. Best next step is C. diff toxin. Dermatology. So acne is treated in tiers. So the first line of acne is topical benzoyl peroxide or topical retinoids. If that doesn't work, then you progress to topical antibiotics. If that doesn't work, then you move on to oral antibiotics. And then the last line is Accutane, isotretinoin, and that's basically your big gun. So rosacea is, think of a middle-aged woman who has a flushed red face that looks almost kind of like a combination of sunburn and acne and kind of like a malary rash, and you want to treat that with metronidazole. Remember, rosacea is also associated with ocular problems. Keratoacanthoma grows very fast. Patient gets concerned. What should you do? The answer is reassure, because it'll go away on its own. Seborrheic dermatitis, this often has scales and skin flaking in the nasolabial folds, over the eyebrows, in the hairline. You treat it with selenium sulfide shampoo or azoles, and then remember that key association is it's associated with HIV and Parkinson's disease. Contact dermatitis is a type 4 hypersensitivity reaction, can be due to poison ivy or latex allergy or neck contact with certain metals, and it's very itchy, it can blister, and it's treated with topical steroids. Pityriasis rosea, it is the one that starts with a herald patch and then later creates a bunch of macules that are arranged in a Christmas tree pattern. It's not contagious, it goes away, but you can treat it with antihistamines. Erythema multiforme is on the spectrum of Stevens-Johnson syndrome and toxic epidermal necrolysis. It's kind of like a target lesion, and it can be caused by sulfa drugs or HSV. Stevens-Johnson syndrome is caused by apple PCs, allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfas. And then if the lesions become greater than 30%, this is called toxic epidermal necrolysis. You should know the difference between bullous pemphigoid and pemphigus vulgaris, which is autoimmune. So pemphigus vulgaris goes after the desmosomes, and then bullous pemphigoid goes after the hemidesmosomes, which attaches the skin cells to the basement membrane. The difference between the two is that bullous pemphigoid has no oral mucosal lesions, whereas pemphigus vulgaris does. And you treat these with steroids. A zoster vaccine happens at 60 years old. Why? To prevent herpes zoster, which is the vesicles that can appear along one dermatome along the ribs, which can have the complication of herpetic neuralgia. And also, one of the rare manifestations of herpes zoster is it can appear over the V1, V2, V3 dermatomes as well. Dermatophytes, remember tinea capitis, tinea corporis, tinea cruris, tinea pedis. Tinea capitis, know that it's treated with oral griseofulvin. The rest of the body can be treated with topical azoles. And then remember that tinea lesions are kind of rough and scaly looking with a central clearing. Scabies, very, very itchy. Think that the itching is much worse at night. Usually the vignette will say one person had it, the itchiness, and now another member of the household has the itchiness. They'll show you a picture of someone showing their hand, and it'll be like, in the webs of the fingers, you'll see little blisters, dry areas with little tunneled tracks, which are the little scabies burrowing underneath the skin. And then the key thing is extreme itchiness, and the treatment is permethrin topical for the whole entire day for everyone in the family, and also burn all your clothes. Just kidding. Put all the clothes and laundry stuff in a plastic bag, and then wash it with extremely hot water. But the main thing is, remember permethrin and how to diagnose. Very, very itchy. Actinic keratosis, they'll show you a picture of an elderly person who has worked outside their whole entire life, and it'll be like a scaly kind of lesion that looks almost kind of like dry skin that's scaling, and it'll be on the head usually or arms. Remember that this is treated with topical 5-fluorouracil. You also need to biopsy it because it has an increase of transforming to squamous cell carcinoma. Basal cell carcinoma versus squamous cell carcinoma. Squamous cell carcinoma can have very atypical appearances, but for our purposes, basal cell carcinoma, remember pearly telangiectasias, very pearly looking, shiny, and then if you look closely, you'll see little dilated blood vessels. The marginal ulcer, think of a wound, a chronic wound, someone who has maybe a diabetic ulcer that has not healed. It keeps healing and then reopening up and healing and reopening up over many, many decades, and this can progress to squamous cell carcinoma, so you want to biopsy it. And lastly, anaphylaxis due to some sort of food allergy or bee sting, like a peanut allergy. The person in the vignette will have eaten and then shortly after had wheezing, difficulty breathing, hives appearing all over the body, and on blood pressure they are hypotensive. What's the best next step? Intramuscular epinephrine. Retinal artery occlusion. Retinal artery occlusion. Cherry red macula. Retinal vein occlusion. Blood and thunder retina. Some pediatric cherry red maculas too. Remember Tay-Sachs disease and Niemann-Pick. But Niemann-Pick also has hepatomegaly. CKD or diabetes mellitus with proteinuria, first line is ACE inhibitor. Remember, angiotensin likes to constrict the efferent arteriole, which increases glomerular pressure, which increases glomerular filtration. So when you use an ACE inhibitor, you get vasodilation of the efferent arteriole, which reduces pressure over the glomerulus, which reduces proteinuria. So it's considered renoprotective. Best at lowering triglycerides is fibrates. Only want to use fibrates when the triglycerides are over 1,000. Also, hypertriglyceridemia associated as one of the causes of pancreatitis. Best at increasing HDL is niacin. But even though I say this, Remember that first line for hyperlipidemia is statins. And remember that there's 4 people who get statins. Those who have current atherosclerotic cardiovascular disease, anyone with coronary artery disease or peripheral vascular disease. The second is diabetics over 40 with the LDL over 70. The third is healthy people with the LDL of over 190. And the last person is a person who is over 40 with the ASCVD risk of greater than 7.5% with the LDL greater than 70. These are the 4 people who get statins. First line for cluster headache, remember, cluster headache is the person who has one-sided eye discharge, one-sided eye pain, described as very sharp, unilateral runny nose, and extremely sharp pain behind the eye. This is a cluster headache. The number 1 treatment is oxygen. Prophylaxis is a calcium channel blocker such as verapamil. Versus tension headache, which is bilateral and band-like. This is actually just musculoskeletal headache due to stiff neck or bad posture, and this is just treated supportively. Migraine headache is the unilateral pounding, can cause nausea and vomiting, can be debilitating, worsened with noise, can also have auras, which can be strange neurological deficits, sometimes can even present like a stroke, and that can be tricky, but the key here is to look at the age. If there's a young person with a bad headache and dysarthria or like hemiparesis that resolves, and they're like 20 years old, this is most likely a migraine with aura. And the migraines you want to treat if it's severe or refractory with sumatriptan, which is a serotonin agonist, or prophylax with beta blockers or TCA. Post-nasal drip, which can cause upper airway reactive syndrome, which is a post-nasal drip that causes a cough. First line is antihistamine. Someone who has allergic rhinitis though, which is just constantly runny nose due to allergies, the first line is intranasal steroids. Bloody stool plus fever. Next step is stool white blood cells. If the white blood cells are positive, the next step is stool culture. If negative, symptomatic treatment. If you suspect C. diff, next step is C. diff toxin. Bowel obstruction, next best step, X-ray of the abdomen. Anything with an acute abdomen, you always do X-ray of the abdomen because it gives you more information, but most importantly, it rules out pneumoperitoneum, which presents with free air under the diaphragm, which is an indication for surgery. Irritable bowel syndrome, think of alternating constipation and diarrhea, and the kicker is it's alleviated with defecation. Interstitial cystitis, the patient has all the symptoms of UTI, dysuria, increased frequency, increased urgency, but the urinalysis has no markers of a UTI and or the antibiotics did not work. This is interstitial cystitis, and the kicker is alleviated with urination. Disc herniation versus spinal stenosis. Position. With disc herniation, bending over hurts, extending feels better. With spinal stenosis, extending feels worse and bending over feels better. Don't just think, oh, shooting pain down the legs, oh, slam dunk for disc herniation. No, make sure to confirm the positional changes and what makes it better or worse. Remember, someone with disc herniation, the best next step, symptomatic treatment such as physiotherapy and analgesics, and you don't do an MRI quite yet until later on, because a lot of times disc herniation symptoms will resolve if it stays for like 6 weeks, or if now they have scary neurologic deficits like incontinence or paralysis, then you do an MRI. But usually the correct answer for someone who has disc herniation is first recommend supportive treatment before the MRI. Indications for MRI of the spine is if you fear Cotta-Aquina syndrome, right, which is lower motor neuron deficits, right, hyporeflexia, flaccid paralysis, fasciculations, urinary incontinence, decreased anal sphincter tone, or like saddle anesthesia, those are indications for an immediate MRI. Or someone who has epidural abscess due to seeding from an infection, that will also cause fever, point tenderness, and neurologic deficits. That's also an indication for an MRI of the spine. Versus metastatic back pain due to a cancer, that person will have point tenderness to the back, and it'll be back pain that is really bad, especially at night, that points towards metastatic cancer to the spine. The first line for that is an X-ray. And spine metastasis cancer, you want to treat with opioids and radiation if the opioids don't work. Osteoarthritis, the number one risk factor is obesity. So in most osteoarthritis vignettes, the person's BMI will be over 30, and it gets worsened with use throughout the day, versus rheumatoid arthritis, which is improved throughout the day. Treatment for osteoarthritis is analgesics and to lose weight. Osteoporosis, remember, DEXA scan happens at age 65. If it's less than -2.5, that's osteoporosis. And first line treatment is bisphosphonates, in addition to weight-bearing exercises plus vitamin D plus calcium supplementation. But the answer will be bisphosphonates. You can have open angle glaucoma or closed angle glaucoma, and it can be, the dangerous one is acute closed angle glaucoma. This presents with a rock hard eye with non-reactive pupils. The person will see halos. They'll have very painful red eye. And with angle closure glaucoma, remember that meiosis helps. Why? Because when you stretch out the iris, that opens up the trabecular meshwork, which allows for aqueous humor outflow. So you want to give any drug that would promote meiosis, such as pilocarpine, which is a muscarinic agonist, which promotes meiosis, in addition to beta blockers, which decrease aqueous humor production. Blepharitis is inflammation of the eyelid. It will present with crusting over the eyelids in the morning, usually in a kid. It's most likely caused by Staph aureus, and treatment is scrubbing the eye in the morning with warm water and a warm compress. Versus bacterial conjunctivitis, which is purulent discharge out of the eye. This is also caused by Staph aureus, but in this case, it needs to be treated with antibiotics. And think if there's pus, then you treat it with a macrolide such as erythromycin. First line treatment for obesity is lifestyle modification, but if that doesn't work, then second line is orlistat, which is a pancreatic lipase inhibitor. Also, what are some indications for bariatric surgery? If the BMI is greater than 40 or greater than 35 with comorbidities such as like debilitating osteoarthritis. So you have stress incontinence, overflow incontinence, and urge incontinence. So stress incontinence is associated with multiple pregnancies and older age, and this is due to the internal urethral sphincter falling below the pelvic diaphragm muscles. And so anytime they valsalva, like cough or sneeze, then that increases pressure over the bladder, but the internal urethral sphincter won't compress like it normally does, because usually it's above the diaphragm, so the bladder and the internal urethral sphincter both compress, so nothing happens. But in this case, the internal urethral sphincter will have less pressure versus the bladder, which causes leakage of urine. In this case, the Q-tip test will show urethral hypermobility, so the Q-tip angle changes a lot. And then also the first line treatment for this is Kegel exercises, and if that doesn't work, the second line treatment is a pessary, which is a plastic device which is inserted through the vagina, which helps hold the bladder up higher. And then the third line treatment is a mid-urethral sling. Versus urge incontinence, which is caused by sporadic spasming of the bladder, and then this person will have the urge to pee and they won't be able to control it because it comes out of nowhere. And then the treatment for this is bladder training exercises, and the second line is something that will relax the detrusor, such as oxybutynin, which is a muscarinic antagonist. And then there is the final one is overflow incontinence, which is also known as neurogenic bladder, which is seen in patients with severe diabetes with neuropathic complications, or people who have spinal cord injuries, or people who have had recent surgery and the anesthesia has stunned their bladder. And so basically the first line treatment for this is intermittent self-catheterization, and if that doesn't work, then the second line treatment would be bethanechol, which is a muscarinic agonist. And then treatment of alcoholics is naltrexone or acamprosate. Treatment of smoking cessation, first line treatment is nicotine gum and patch. And then other possible treatments are varenicline and bupropion. Varenicline is a partial nicotinic acetylcholine receptor agonist. Its famous side effect is suicidality, and bupropion is famous for its contraindication, which is it's contraindicated in people who have seizures, eating disorders, or alcoholics because it lowers the seizure threshold. Bupropion is also an antidepressant that's famous for not having the side effects of weight gain or sexual side effects. Colon cancer screening, start at age 50. Every 10 years, you stop at age 75. If you find a polyp, the worst is a villus adenoma, then you repeat the screen in 3 years. If someone in the family less than 60 had colon cancer, then you do it at age 40 or 10 years before the family member was diagnosed, whichever one comes first. Pap smears start at age 21, end at age 65, and happen every 3 years. HIV testing happens in anyone who's sexually active with between ages of 15 to 65. Mammograms start at 40 years old and happen every year. DEXA scans happen at 65 years old. AAA screening happens at 65 years old in any male who has ever smoked. Pneumovax vaccine happens at 60 years old as well. Zoster vaccine also happens at 60 years old. Lung cancer screening starts at 55 years old for anyone who's ever had a 30-pack year smoking history, who currently smokes, or who has quit within 15 years. Chlamydia and gonorrhea screening happens in all women less than 24 years old. Hepatitis A and B vaccines happen for men who have sex with men, IV drug users, people with hepatitis C, or chronic liver disease. Why? Because hepatitis A or B infection superimposed on pre-existing liver disease is catastrophic and can require liver transplant. Having a cold or fever is not a contraindication for getting a vaccine. Breastfeeding is okay if you have gotten a vaccine. Don't breastfeed if you have HIV, or if you're on chemotherapy, or if you're a drug user. All military and college people should get a meningococcal vaccine. Cephalosporins are lame. They can't treat listeria, atypical pneumonias, MRSA, or enterococcus. Metronidazole, get GAP on the Metro. Alright guys, and that wraps it up for high yield internal medicine. I hope this is really helpful for you and helps you succeed in your shelf exam or for your step 2 CK preparations. If you have any other ideas, or if there's anything else you would like me to expand on or talk about, then please let me know in the comments below. And all the best in your studies, guys. Good luck.